Okay, good morning, everyone. So Zahra, if you can hear us, we will start our session today. Dr. Arash will be with us in few minutes. Also, hopefully we will have our director for program management, DPM, Dr. Rana Hajja, also today with us for some of the sessions. So we will start with the recap of the day, and then we will do the rest of the sessions today. Thank you so much. Zahra, please, over to you.
Great, thank you. Good morning, everybody, and I hope you can hear me well. My name is Zahra Karimian, and I am a consultant at the Evidence and Data to Policy Unit, and I've served as the coordinator for the Regional COVID-19 Vaccine Effectiveness Study by EMRO since late 2021. I will be providing a recap of first day's session, especially with key points, particularly for colleagues who may have not been able to join us yesterday or only joined some sessions. Next slide, please. Next slide, please. Thank you. So we began yesterday by talking about the WHO's guidance and protocols for the evaluation of COVID-19 vaccine effectiveness study since the pandemic and the revisions that they've come up with since then. We did talk about how randomized controlled trials remain to be the gold standard when we're evaluating vaccine efficacy, but observational studies or vaccine effectiveness studies remain to be necessary because after we introduce them into the general public, we need data that are collected under conditions that are in the real world and not so controlled, like RCTs. The WHO has first put out its guidance for the evaluation of COVID-19 vaccine effectiveness study in March of 2021. It was primarily intended or had in mind low and middle income countries and settings, and they came up with two addenda, one in July of 2021 and then one later on in October of 2022, talking about important considerations such as the use of rapid antigen tests, the definitions and how we consider them, the covariates that need to be collected, how to consider or account for biases and co-founders in our studies when we're analyzing the data, and the different types of immunity from hybrid immunity, relative and absolute VE, and a lot more. If you're interested, that guidance is available online. But we did talk about eventually two main WHO approved methods, the test negative design and SARI, and the cohort study among healthcare workers, which were recommended to evaluate COVID-19 vaccine effectiveness. And those are the ones that we adopted in the region for our study. We did also talk about one important reference that the WHO has jointly been updating with all published VE studies regularly. It's viewhub.org. Up to November of 2023, there's been 428 primary series and 267 booster series that are been studied, and those results are also available through that resource. Next slide, please. So for the regional COVID-19 vaccine effectiveness study, there were two main approaches that we used. One was through enhancing the processes and structures in the region, and the other one was through building national technical capacities. We talked about, for the structures and processes, how we established a dashboard to monitor the studies in the region. We then standardized the designs and methods, and then obtained ethical clearance for our study. And then we developed a central data entry platform and REDCap to collect and gather and monitor the data. And finally, we did all of this through putting together a multidisciplinary technical team. And then the capacity building was done through two methods. One was through region-wide workshops, and the other was country-specific trainings. Next slide, please. And the main objectives from establishing this regional COVID-19 vaccine effectiveness study were to ensure the quality of the study results that were collected from the participating countries. And that was, of course, done through standardizing the methods and using uniform code books. The second one was, of course, to facilitate data sharing between the countries and the WHO EMRO, or with us rather, through regular data collection and monitoring in that platform. And of course, through the recurrent technical meetings and site visits, we'd be able to offer feedback. And then finally, we intended from the data that was used to be pooled, and hopefully we'd have a higher statistical power. And of course, through the capacity building program and establishing this platform, we were hoping that it would be sustainable for future studies. Next, please. So we did talk about some of the challenges and lessons learned from conducting the regional study. There were some challenges that were inherent to the COVID-19 vaccine effectiveness study itself, COVID-19 being an emergent disease and this being an observational study. The other one were specific challenges that countries experienced themselves. Some countries had some difficulty in obtaining the necessary clearance. Some countries during Ramadan had difficulty obtaining samples. And then finally, some of these challenges were because we were conducting a multinational or regional study, being able to get all the studies harmonized and then collecting all their data and doing a pooled analysis poses its own challenges as well. And then finally, we talked about some of the future needs that we identified, which are being able to continue the implementation of VE studies to generate evidence for policymaking in the future that would require linking different data sources so that they can crosstalk, and then integration of this model into the primary healthcare service. We emphasize the importance of also looking at adverse effects following immunization alongside VE in order to make better decisions when it comes to immunizations. And then finally, identifying a sustainable way to finance vaccine supplies and research globally. Next, please. The other regional study that we had the privilege to hear about was the study from PAHO. They had actually a network for evaluation of VE in Latin America and the Caribbean for influenza, and they were able to successfully leverage the existing SARI Sentinel surveillance system for COVID-19 in 2021. Their regional study actually included 5 countries, Argentina, Brazil, Chile, Paraguay, and Uruguay. And then they conducted a multi-center test negative SARI method for their study. And they categorized their variables by patients, clinical and lab outcomes, and vaccination. And their study results have recently been published in Lancet Regional Health. So if you're interested, the link is there for you to look into it. But an important message was that they experienced many of the same challenges that we did in our study in EMRO. Next, please. So then we had presentations from the individual countries that participated in the regional study, namely Iran, Jordan, Egypt, and Pakistan. I'm summarizing the key messages from all of them. There were differences in the data sources that were used and the validation steps and processes for them, of course, by the investigators themselves, apart from what we did at EMRO. They talked about how VE estimates might be less than optimal because of the many different vaccine types and schedulings that were used, and the potential for classification errors and doing observational study with registry data. And then COVID-19 vaccine effectiveness study, COVID-19 VE against symptomatic COVID-19 infection and severe disease was overall found to be beneficial, and then waning immunization confirmed the need for booster doses. And I think a common message was that the emergent variants necessitated the generation of new vaccines for the future, and that it's important to also report statistically non-significant results and negative VE results while citing their limitations. Next, please. Then we had some of our other countries that independently from the WHO had also conducted their vaccine effectiveness studies on COVID. They had used different methods and study designs, but in general, they had used national electronic health records. These were from Qatar, Saudi Arabia, and the United Arab Emirates. And the capacity for genomic surveillance and the epidemiological expertise were identified as key contributing factors to the success of those studies and offering valuable insights. A very important message was that the partnership between academia and public health sectors really emphasized the use of evidence generated from these studies for policymaking in those countries. Next, please. I believe this is my final point. A highlight of the discussions. I've just put 3 here. One of the suggestions that we received, which was really well received, I suppose, was having a one-page summary of the study results from different countries' studies in order to share those results with the ministries of health to facilitate the policymaking for immunization programs. We also discussed the possibility of pooling results across countries, not just the ones that participated in the regional study, but other studies from the region where they had used similar designs and methods to get a more robust estimates. And then finally, the provision of technical support, either through the capacity building programs that we had offered or opportunities like the technical consultative meeting where people could exchange their findings and their ideas were found to be beneficial. So I believe that's it. Thank you for your
few words on that one. So let's go to my presentation. So what I'm going to talk about, so this is my guiding tool. Yeah. I'm going to talk about a bit of history, what happened during the time. And all of us are here more or less for most of the work we did. This was actually during that history of the pandemic, something, as I mentioned yesterday, and I think I share this feeling with many of you and many others, that, I mean, those years seems to be a sort of bizarre period of time. And we hope that in our lifetime, nothing as serious as that happens to humanity with so much loss that happened. So the work that happened. So within that structure, I mean, within the WHO, I mean, we established, I mean, in every emergency, now for the Palestine emergency, there is an IMST, incident management team structure that would actually coordinate all the emergency response of the WHO. So we have it for different outbreaks. It could be for an earthquake, it could be for a war situation, and that coordinates everything. So obviously we had an IMST that is globally and at the regional level, and then every country itself has its own IMST with the structure to coordinate all the functions. What this regional office did was sort of an innovative approach. I mean, early on when the structure of IMST was being finalized, we actually decided that we would have a pillar for research and knowledge management. This was in a way different from anywhere else in the WHO. And the main purpose was that to actually coordinate all the work that is happening on research, on sort of generation of evidence, but also at looking at the existing evidence and sort of supporting generation of evidence at the same time. So a bit at the start, the first, I would say, few months was a bit difficult to coordinate. So different teams were doing different things at the same time, especially with the other structures of the WHO. So, I mean, we usually coordinate very well, but then this pillar, how to coordinate with the other pillar is what was not that very clear. But as time passed by and with the extremely, I would say, heroic commitment of the colleagues, and which was across WHO as a whole, I mean, it actually proved a very successful approach. So in a way, it allowed us to do much more than what was usual, but it also allowed us to bring the teams together much closer for such issues. And we are hoping that experience, and we are still using this experience for the future events. So this is coming, in a way, it's a very quick report of what happened during those sort of the work of the IMST. And so it's not only our department, it's, I mean, colleagues from all departments were engaged in that. So, and some of those colleagues are sitting on this table. So I go back to the name of colleagues later at the end of the presentation. But just let's remember, this is a slide actually I gave I was invited to a meeting to discuss about the science on COVID pandemic, early on in the pandemic. And I put the question, the things we don't know at the time, we didn't know. We weren't sure about the origin. We weren't sure about how to diagnose it. We weren't sure how to treat it. We didn't know how it spreads around. There were a lot of doubts whether mutations even happen, or if they happen, what would be the extent. So many questions on different aspects. So, and that's a good reminder to, when we look at this list, still some of these questions are not fully addressed. For example, on the sort of, I mean, social strategies, on the distancing policy, on the effectiveness of other approaches, there are questions we don't know. On the behavior of the virus in terms of the sort of mutagenicity, I mean, still there are questions. The way that vaccines might affect at the long run, which is one of the reasons the importance of this meeting, still the questions remain. So this was the situation. And then within that situation, I mean, the WHO and the ministries of health and the countries were making important decisions all the time. So as I mentioned, the pillar was established. I mean, the focus was to enhance capacity for evidence generation, timely provision of available evidence to countries, and enhancing capacity for sharing and use of evidence. So now I go to a series of studies that were conducted. A series of studies we did were actually household survey studies. I mean, this is a list of those studies and about the timeline of their conduct and their reporting. I mean, so include the studies that were directly and financially supported by the WHO. And also, I mean, this is almost every study on the list. But then also for UAE, there was no financial support, but technical involvement with the country for the conduct of the survey support for the team who was doing it. But then, I mean, there were different formats, different approaches, and within this also some of those contexts, the way of doing the household surveys with the very strong involvement of Ministry of Health staff was not very common in some of the countries, which again was part of the capacity building for that process. These surveys, they contributed to several policymaking processes in the countries. I mean, there were many examples. I mean, Saverio can tell us a lot about how the survey was used in Jordan for policymaking, and we have cases in Afghanistan, in Pakistan, I mean, in Yemen and other countries. So I'm not going through those details. The other issue is that, which I'm not going to talk about at all, is the reason why you are here, the vaccine effectiveness study. So again, this was a global initiative to do it, and I'm really glad that colleagues from other regions of WHO are also with us here, and our colleagues from HQ have joined efforts on these areas. And within those areas of work, I mean, the 4 studies and how to take it forward. The main factor for me is also what to do next after this in terms of such studies. And that would also feed in the overall WHO policy for support of large-scale study, which is not the common approach of WHO. So in terms of the policymaking processes and also supporting countries, I mean, obviously, I mean, another major study you all should remember, I mean, you should recall. So, I mean, the Solidarity Trial, and then several countries of the region were heavily involved in that. Probably one of the countries that provided the most cases was Iran, I think globally. I'm not talking about the region in terms of cases, that because the number of hospitals was quite large, and also they used the structure they had for randomized controlled trials, and they devoted it to that study. So, but then, I mean, also several other countries were heavily involved in that process. In terms of the call for proposals, we had different rounds of call for proposals. I mean, 2 specifically for COVID-19 questions were announced. And so those areas of work were also expanded. And these were, I mean, I think in terms of call for proposals during the pandemic, I mean, EMRO, we have a tradition of, we have usually every 2 years, 2 what we call it, widespread call for proposal for small grants, small research grants. So during the pandemic, we had 5 during the that period. So it was actually quite a massive expansion, using resources to focus on the questions of the day, supporting countries for that. There were studies on mortality reporting. So, I mean, I'm not going through the details of these analysis. There has been much more updates since this. I mean, a global report came out. You all should remember on the estimated mortality, confirmed mortality due to COVID, and different gaps in assessment. But I mean, this is the case of 3 countries. So if I remember correctly, Lebanon, Jordan, and which was the other one? Oman, Lebanon, Oman, and Tunisia. Sorry, not Jordan, slipped off my mind. So in a way, specifically, I mean, for Lebanon and Oman, I mean, this reporting was actually an enhancement of the way the country was actually reporting on the mortality data. So Oman has a strong CRBS system, and they were good in reporting in general, but they made it much more frequent. It became weekly reporting on mortality because of this reported, and Lebanon expanded the capacity to do such work. So in a way, it also enhanced the national capacity for recording and reporting on mortality. Then one key work was to share evidence. I mean, obviously the EMRO journal, I mean, in the region, I mean, the number of submissions to our journal during the pandemic doubled. I mean, more than doubled. the number of papers being submitted to us. And so in a way, and then we prioritized COVID-19. Everything that came was relevant. If it had the quality, we went through it. But then also we developed a health knowledge management portal tool. I mean, my late colleague, Mr. Hatem Nureddin, developed the tool, and he passed away a couple of years ago. I mean, over a year ago, due to cancer. So, and he did a great job in that. And then that became a source of, I mean, sharing the data. But more important, it was evidence summaries to the IMST. And this was the thing that we were doing it as part of the responsibility. The first 6 months, it was more or less every day a summary of the latest evidence. So that meant we had to look at the evidence up to about 7, 8 p.m. the night before to summarize it, to be able in the morning to be up to date, because the way that the studies were coming out, evidence coming out. But then later on, after the first 6 months, it became, I mean, 2-3 times per week, then became weekly, then became monthly, as the sort of the requirement for that became different. So again, all of these experience we are hoping to use further. So these are the list of the studies that supported, I mean, specifically for the pandemic in these countries. I mean, these are small grants, so I'm not going to go through those. What really important, this is a study we did about, I would say, 18 months after the start of the pandemic. So, and this was, we looked at the randomized controlled trials registered from countries of the region in the global registries of RCTs. So that was what we were doing. And those that are having anything to do with COVID and registered from one country of our region. And the picture wasn't really good at all. I mean, there were many studies that were really a small sample size. I mean, sample sizes of less than 100, I would say. I mean, and you want to assess effectiveness of something for COVID, which is impossible. Assessing medicines or medicinal products or ideas that you had no theory whatsoever that they might be effective for COVID-19 pandemic. Assessing things that had no specificity for COVID. So for example, why do you do a trial of which medicine reduces coughing on patients who have COVID? Why to do that? I mean, because if the focus is only on coughing, it can be on any population. So in a way, it's as if, I mean, the environment had been used for such issues. I mean, one example that I usually don't put it in the slides, but I'd say it verbally. There was a sort of a trial of, I mean, and that was a relatively large sample size. If I remember correctly, it was close to 1,000. And testing donkey milk on COVID patients as a potential treatment. Imagine that. So it was registered in global sort of RCT records, which means it had ethical clearance. So an ethics committee had cleared it. So that's just imagine that. And so then the issues of, I mean, sort of hydroxychloroquine studies, obviously, I mean, there were a lot of questions whether it works or it doesn't work at the time. But then many tens of studies registered in certain countries. There were maybe 20 studies in one country going along, all of them small size, but not a large scale randomized control trial being done in the country to actually make it something useful. So in a way that it was sort of, I would say, mind-boggling. The one slide I could have added was the issue of that, I mean, we actually look at also the status of guidelines, national guidelines for COVID-19 pandemic, and and that's a study that, I mean, Mehnaz Zahra, who is online with us, and another colleague, Chiori, they conducted on countries of the region. So 10 countries of the region, the national guidelines of the time were analyzed, and against the evidence that existed at the time the guideline had been released. And the picture wasn't really good. I mean, there were recommendations on those national guidelines that were not based on the best available evidence of the time, not the evidence that came later on that we knew. And there were actually, I mean, important weaknesses in the process. And we used that to have a discussion with ministers of health of the region just in October. So as a WHO, I mean, in the region, we are working more closely with countries to enhance their national guideline program. So we just wanted to show, so this is the situation. If the guideline program is not strong at the time of emergency, things can go anywhere. Anyway, so concluding remarks, I mean, the role for, I mean, the support of key research, I mean, the research helped for us. But then, as I said, collaboration research is lacking. That's a key issue. And the need to enhance the governance of research in the countries became very, very clear. And these are the areas that we are hoping that by next year, we would have a new strategy. In a way, what would be our responsibility to support countries further? And as I mentioned, I mean, many colleagues, so the list of colleagues in the pillar are here. So, I mean, we had Amal with us in the room and other colleagues. I mean, and these are only colleagues who were working at the regional level. But then several colleagues were also in every country office involved in the process. Okay, many thanks.
Thank you so much, Dr. Arash, for the excellent presentation and great points that you just shared with us. So now is the time for this, our third presentation, Dr. Amal Barakat, Technical Officer in Department of Health Emergencies. So could you put her slide, please?
I thought Rick will present before me. Yes, I can imagine. I mean, and you can imagine how much in the 6th floor. It's very busy with the more than 50% of countries now in emergencies, complex situation. So Gaza, it's another one who is really unique situation, needs unique, exactly. So I will briefly, I mean, talk about how we adapt. I mean, the influenza program in EMRO to advance in COVID response. I mean, we are IHP, I mean, infectious hazard preparedness. We are hosting the influenza program. So influenza program, it's not the only influenza pathogen, but it's an influenza program and other respiratory diseases. So since the beginning of the pandemic, I mean, the existing influenza surveillance system, when we say the surveillance system, it's not one. I mean, the countries are using many surveillance systems. The whole platform and capacity have been leveraged for virus detection first. We needed to diagnostic, reporting, risk assessment, and sharing of material and data. You can imagine, and all of this, I mean, supported by the global influenza surveillance and response system, the GISRS. This is, I have put here just some of the documentation, I mean, and guidance, I mean, needed for the whole network, I mean, to support these adaptations. So, I mean, for people here, I mean, who are not very familiar with the GISRS, the Global Influenza Surveillance and Response, I will give just a very brief summary. I mean, this network, I mean, have been established in 1952, I mean, to respond to the persistent threat of seasonal, zoonotic, and pandemic influenza. It started with very few international labs and public health institutions, but it growing over years. And currently, it's included more than 160 institutions in around 130 countries. So you can imagine, I mean, how big the network is. It's one of the strongest network coordinated by WHO. And it's, I mean, the backbone of this network is the National Influenza Center. This 160 National Influenza Center are responsible to collect the SARI and ILI samples from the SARI and ILI sentinel sites to do the analysis, further analysis, and to send representative samples up to 4 times, I mean, to the WHO collaborative centers who do further analysis for vaccine, VCM, vaccine composition. You know that we organize 2 vaccine composition per year. I mean, one in February for Northern Hemisphere, the other one in September for the Southern Hemisphere. And of course, these NICs are sending immediately whenever they have any samples and subtypable samples. So means this is how the network is working. So currently, the network is really testing and collecting and testing more than 4 million samples per year, and around 40,000 viruses and clinical samples are shared with with collaborative centers. For, of course, I said the VCM, the vaccine composition, but also for the global risk assessment. And one key is the reporting. I mean, you know, this is influenza, it's really outbreaks is in real time. So we need the real-time reporting. This is why these NICs and their surveillance departments, I mean, they are reporting on weekly basis the virologic and epidemiologic influenza related to year-round through the regional or the global database, which allows, of course, the WHO to distribute on timely the risk assessment and alert to countries. So it's very dynamic network. The WHO and, of course, the partners, and one of the biggest partners in the CDC in Atlanta is working really closely in continuing basis to enhance the capacity on all countries. I mean, the epidemiologic and also the virologic capacity. And of course, the reporting through this global platform. I said this is what we, it was again enhanced during the pandemic, and we call it now the RespiMart instead of FluMart. It was updated to review it, I mean, to include all the high priority respiratory pathogens. So now we are using it for COVID and for RSV. So all the respiratory diseases are integrated under this global database platform. And of course, this network, I mean, it's supported by many initiatives. I mean, global mechanism. I mean, all the NICs in the world have access to the influenza reagent resources. I mean, they are receiving standardized kits and key supplies. So they are using the same protocols, same standards protocols. They are shipping whenever they have to the country, the collaborative centers through the shipping fund project. So this is free for them. It's easy. They just need to send an email to Geneva, who is coordinating, and the World Courier is taking the samples very easily. ECAP, of course, this is how we are monitoring the quality for this network. So this NICs needs to take a part yearly the external quality assurance program. And of course, some countries are really benefiting from the PIP, the Pandemic Influenza Preparedness Framework, established in 2011, with the concept that sharing viruses equal access to vaccine and other benefits. And of course, GISERS is really monitoring the viruses in the animal, which can have be a threat for human. We are working very closely with the International Animal Health, FAO, and OIE. So this is the international network. So coming to the Eastern Mediterranean region, so this is how I will give you just a very brief overview of our regional network, who is part of the GISERS. So here, out of the 22 countries, we have 19 who have a functioning SARI and ILI system. OPT have non-sentinel, means that they have the SARI surveillance in all hospitals in West Bank and Gaza. Kuwait are still reactivating. So we are missing only one country, which is Djibouti, without functioning SARI and ILI systems. And 10 countries, and you have seen, this is the low and middle countries, they are benefiting from the PIP. To enhance their surveillance systems. We have also established a regional database. This is the MFLU. Now we moved from MFLU 1 to MFLU 2 we are expanding to other respiratory. So Influ-2 is really including the COVID, RSV, and other priority pathogens. So the countries are using Influ in two options. I mean, they can use it as their database, like in Saudi Arabia, it's connecting the Sentinel sites with the lab, with the surveillance department. So and some countries who have their own database, they are just we synchronize, or they send the data to the Influ. But this is the database. I mean, really supporting the enter the data, the process, and reporting to EMRO, and this Influ-2 is synchronized with the Respimart. So whatever we have in Influ, it's in Respimart. Coming to lab, I mean, as I say, the NIC is really the backbone of the network. I mean, they collect the SARI and ILI samples. They do the primary analysis. You can see their capacities. They have variable capacities, but all of them, they have molecular capacity. PCR, some are more advanced. They have the capacity to culture, to do the drug susceptibility sequence, but all of them, they have now the sequencing capacity. I will come back to the sequencing. So this most of them, we have 18 NICs now in 18 countries. On the blue, Libya, Yemen, and Somalia are the ones who have a national, we call them national influenza lab. They are still not recognized by WHO. I mean, they need all of the NICs. I mean, they are institutions who are designated by their national authorities, and we are designated, and we include them recognize them as the WHO NICs. The only one we are still missing, I said, is Libya, Yemen, and Somalia. We are still working on this. And all of them, without exception, have been designated COVID lab from the beginning of the pandemic. So as I said, I mean, this is the infrastructure. This is the regional, the global. So since the beginning of the COVID, I mean, all the countries used this system for COVID. I mean, because of the human resources capacity, these people are well trained. I mean, on epidemiology, lab. I mean, they know how to deal with emerging respiratory pathogen. They are dealing with seasonal, and they are dealing with emerging respiratory pathogen. The process, data, specimen collection and testing and the reporting is in place. Existence of the NICs, I mean, it was really helpful in the beginning of the pandemic. I mean, within 1 week, I mean, we just sent them the primers and probes. I mean, they needed, and they started to test very easily. And all of them, as I said, I mean, they were designated by their countries as a national lab. The WHO data platform, I mean, it helps a lot. Influ helps a lot at that time, and the Flumart and the Respimart current one. The shipping, I mean, you can, in the beginning, I mean, a lot of countries, I mean, they didn't have the capacity, so they were using the influenza shipping project, I mean, to be able, I mean, to have the capacity in international laboratories. And of course, we included from the first year, I mean, the external quality, including COVID. So yearly they were testing for having the panels for influenza and SARS-CoV in the same time. That was as I said, I mean, the network is working on standardized protocols. I mean, when it comes to how they deal with the specimen, and you can see here, I mean, this is the end-to-end integrated. How in 22, I mean, in January, I mean, this is when we agreed on how we will be dealing, I mean, with both pathogen in the same time. I mean, that was, it took time, I mean, to be fixed within the network, because you can imagine at that time we didn't have the multiplex. You cannot test for multiple pathogen if you don't have the multiplex. It's impossible. So because the IRR at that time, I mean, it was available, the multiplex. So this is what we, all the NICs integrated, I mean, the SARS-CoV with influenza, using the multiplex. End-to-end means that from the enrollment of the cases, the SARI and ILI cases, till the sequencing, this is how a standardized protocol, I mean, the NICs needs to follow up to be able, I mean, to do both. I mean, they are using the Sentinel, but if they can, we are asking them to go to 150 per week, but if they don't have, they can take from a representative from non-Sentinel. So it's very standardized, and this is how we can compare and use all the data. So sequencing, so this is the capacity for the region. I mean, it was really amazing progress coming from non-NGS in the public health laboratories. I'm not talking about you guys, I mean, research universities. I mean, we are talking about the public health labs who are supporting the national surveillance. Before COVID, no NGS, and you can countries, I mean, the richest countries, or they just invest a lot, I mean, on training, capacity, equipment, and they have now the best platform, I mean, in the world, I can say. But for those who, the emergencies, complex countries, I mean, we started from scratch, and that was our priority. We implemented, established, I mean, the sequencing with using nanopore in all countries for SARS-CoV. I mean, we started with SARS-CoV, and we established, I mean, this strategy that we want to expand beyond COVID, and we started with flu, and now they can sequence both influenza and flu, all of them. And now we are expanding to other high priority pathogens like cholera for priority, where the country suffering from still from cholera to CCHF. I mean, this is our strategy. I mean, we are expanding this sequencing. I mean, I know that sequencing sometimes it's research, but for these countries, I mean, our priority is really to be able to confirm the outbreaks as soon as possible. We are using nanopore. It's very small devices who can be sent to high to rich areas and confirm the outbreaks as soon as possible. So what can we achieve with this integrated disease surveillance? I know that we are here to support, I mean, the vaccine effectiveness, but you can see that having a sentinel site within the same patients coming and being tested for all the two pathogens, I mean, can help a lot. So we can simultaneously monitor the circulation pattern. We can assess the disease burden. I mean, the countries started, I mean, all of them, they are starting to expand, I mean, their disease burden to RSV for some of them, to COVID, in addition to flu, risk factor and severe illness for priority pathogens. I mean, established the baseline. I mean, they have for flu, now they are expanding to the other pathogen. Preparedness and response plan, of course, and the impact of the implementation and control measures taking on both pathogens and diseases, and optimizing the use of materials and human resources. So in EMRO, I mean, we implemented and developed, I mean, our strategy, how we will support all the countries, I mean, to implement, I think, the integrated respiratory disease surveillance. I mean, this is in line with the breadth. I mean, all of you, I think you know the new initiative by WHO. I mean, the preparedness and resilience for emerging threats. I mean, the first module is respiratory. We are going with this approach that we group pathogens that have the same transmission mode. So we are integrating all the respiratory infectious diseases in one big surveillance system. It's that this is flu, COVID, RSV. This is the 3 priorities. And of course, flu, it's avian, zoonotic, and so this is how we are putting all the capacities on one system. SARI, ILI will serve for 3 pathogens now, priority pathogens. So I will finish by this. This is the next step. I mean, the GISers have been challenged during the COVID. I mean, it was really a big challenge for all of us, for the network, because these people are coming from one NIC. Some countries, they have just one NICs, some SARI, ILI, but you know, during the COVID, it was tested. So all the countries, I mean, have expanded and implemented universal surveillance in addition to ILI and SARI. So it was interrupted for some countries. Some countries, they are still reactivating, but it's not easy now, the reactivation and update of the network. We have a lot of laboratories with PCR. Do we need all of them? The cost, operation cost, it's very high. Sentinel sites, I mean, how we can keep all these sentinel sites? Do we need them? So we need to discuss the right size. We need to discuss, you are using the same definition for flu and COVID. We know that COVID, a lot of cases, it's not fever, it's not one of the, so this is what we are working since last July, and with the GISers. They established 3 working group, one for epidemiology, one for laboratory, and one for coordination. So this working group are working since last June, just to put same system for the 3 pathogens. So COVID, flu, and RSV for now. So we will finalize. We have the meeting in Abu Dhabi, global meeting with all experts the global experts, to really review the integration surveillance practices. So we will see if we will use the same case definition, or we'll adapt a little bit to include all the cases for COVID and RSV. Still, work is still, I will not say what we define the decision, but it will be finalized and presented to countries, I mean, during this meeting. And of course, to strengthen mechanism of GISers, I said that the network was really challenged during and now we have a big networks in every countries. I mean, we really need to review the real purpose of the system, and how we can sustain this system, how we can integrate the other disease surveillance. I mean, we are talking about priority. MERS is priority in the region, but MERS is sporadic. I mean, we cannot put it as a sentinel. So we need to use what we call now the mosaic, means we need to use the event base, we need to use this other zoonotic surveillance. I mean, we really need to include all this surveillance system in one system. I mean, and sustainable system who can really be used for future pandemic. I will stop here. Thank you.
Thank you, Amal. Thank you so much for the update on surveillance system and platform in EMRO. If you have any questions, we will have a session for discussion after the next presentation, if you have any question regarding the presentations done so far. So now we can just move to our 4th presentation that will be done by Dr. Anshu Verma, Technical Officer in Department of Immunization, WHO HQ in Geneva. Hi, Anshu. She's online with us. Anshu, over to you. Thank you.
Hi, thank you so much. Wonderful, the slides are up. Can you all hear me clearly?
Yes, we can.
Okay, greetings everyone. My name is Anshu, and I'm working with Daniel Feiken on COVID-19 vaccine effectiveness in the IVB department here at WHO headquarters. Next, please. Okay, so these are the 3 questions that we will address. The first being, what is VE over time? The second being, what is VE by vaccine? And the third being, what is VE against XBB, all during Omicron? Next, please. I'm probably going to repeat something here that we've seen a couple of times, so I'll be a bit quick, but I just wanted to give a little bit of an overview before we jump to answering those questions. So these are the VE studies that are included in the Living Systematic Review conducted by our colleagues at the International Vaccine Access Center. And to date, we have about those 520-something VE studies reporting on primary series, a first booster, and a second booster across 50 countries. And most of the VE studies are on primary series, and the least that we have are on a second booster. The Americas region has conducted most of the VE studies, while the African region has conducted least of the VE studies. Next, please. And zooming in on EMRO, about 28 studies covering about 7 countries have been included in the Living Systematic Review. Next, please. Okay, so now to our first question, what is VE over time? And as you may recall in Danny's talk yesterday, he explained about absolute VE and relative VE. But just to remind you, the absolute VE is when we're talking about the reference group, which is unvaccinated, and the relative VE is when the reference group is less vaccinated. So the data that we're going to show you to answer this question is based on the absolute VE. Next, please. So these 2 figures here, they show the results of a meta-regression where an average decline in VE has been calculated after primary series for severe disease on the left figure and for symptomatic disease on the right figure. The y-axis on each figure represents VE, while the x-axis on each figure represents the number of months since a last dose. And each line in a figure represents a study VE estimate. Each color of a line in a figure represents a study vaccine for which legends are shown on your furthest right. What we would want to highlight are 2 observations. The first being that after primary series, the VE declines slower for severe disease, on average by about 1 percentage point than it does for symptomatic disease, which declines by on average 47 percentage points up until 6 months. The second observation is that VE for primary series seems to start higher against severe disease than it does against symptomatic disease. Next, please. In the exact same way as shown on the previous slide, these 2 figures show the results of the meta-regression, but with an average decline in VE after a first booster. So for severe disease on the left figure and for symptomatic disease on the right figure. And we want to highlight actually the same 2 observations, because after a first booster, we see that the VE declines slower for severe disease, on average by 5 percentage points than it does for symptomatic disease, which declines by on average 24 percentage points and up until 4 months. The second observation being that VE for a first booster starts higher against severe disease than it does against symptomatic disease. Next, please. This figure here shows the VE for primary series, a first booster, and a second booster over time since each vaccine administration. We made this figure to give you an overall sense of VE over time, reminding you that this is all during Omicron. So this figure is based on the figures that we just showed you, where we added limited data on a second booster on your furthest left. So on the y-axis, you'll see the average VE, while on the x-axis, you'll see the months since a last dose. Overall, we see a seesaw pattern, and that VE seems to be consistently restored for a first booster and a second booster to the protection level of primary series. And VE seems to be consistently highest against severe disease than it does against symptomatic disease. And then at last, VE seems to be consistently declining slower for severe disease than it does for symptomatic disease. We've not shown you data on infection from the meta-regression, as there were few studies, but from what we did observe, the infection behaves more or less like symptomatic disease. And we are actually in the middle of updating the meta-regression with more recent data on a second booster. Next, please. So now to our second question on VE by vaccine. In the interest of time, we'll zoom in on severe outcomes, especially because we've just seen that protection is highest and most durable against severe disease. And furthermore, we'll focus on some of the vaccines commonly used in the EMRO region. And the data that we'll show you will be from studies reporting absolute VE estimates still. So again, where the reference group is unvaccinated. Next, please. So the plots that we'll show you on VE by vaccine need to be read slightly differently than the previous plots that we showed. On your left, you'll notice a plot showing VE for primary series. On your right, you'll notice a plot showing VE for primary series and a first booster. So the upper part of both plots are representing death, while the lower part of both plots are representing severe disease. The y-axis on each plot represents each study. We're not showing you study details on the y-axis as the plots are pretty compressed at this stage. The x-axis on each plot represents VE. In the plots, you'll notice the symbols on horizontal lines with different colors. And the symbol is the VE estimate from a study, and the horizontal line is the confidence interval. And the coloring represents the study vaccine in question. On your furthest right, you'll notice legend indicating the type of first booster. So the first plot on your left suggests that primary series with the mRNA vaccine of Pfizer offers protection ranging between 75% and 95% against severe outcomes. And the second plot on your right suggests that a first booster with primarily an mRNA vaccine offers protection also ranging between 75% to 95% against severe outcomes. Next, please. Here we're looking at another mRNA vaccine in the same way, Moderna. The first plot on your left suggests the primary series with the mRNA vaccine Moderna offers protection ranging between 50% to 95% against severe outcomes. And the second plot on your right suggests that a first booster with an mRNA vaccine offers protection ranging between 75% and 95% against severe outcomes. Next, please. So here we're looking at vector primary series with AstraZeneca or Sputnik. Let's start with AstraZeneca on your left. The first plot suggests that primary series with AstraZeneca offers protection ranging between 50% to 75% against severe outcomes, while the second plot suggests that a first booster with an mRNA vaccine offers protection ranging between 75% and 100% against severe outcomes. Now let's look at the other vaccine, Sputnik, on your right. So the Sputnik primary series offer protection ranging between 25% and 60% against severe disease. But this is based, as you can see, on few studies, and there's no data on a booster that we have included in the living systematic review, that is. Next, please. Here we're looking at the inactivated primary series with Sinopharm or Bharat. So let's start with Sinopharm on your left. The first plot suggests that primary series with Sinopharm offers protection ranging between 40% to 75% against severe disease, severe outcomes in this case. And the second plot suggests that a first booster with Sinopharm or Pfizer offers protection ranging between 80% to 100% against severe outcomes. But this is also based on few studies. Now let's look at the other inactivated vaccine, Bharat, on your right. So the Bharat primary series offer protection ranging from between 12% to 50% against severe disease. But this is based on few studies, and there is no data on a booster that we've included in the living systematic review. Next, please. So here we show you a plot that compiles VE studies on a second booster against severe outcomes across different vaccine types. The upper legend on your furthest right shows the type of primary series and the first booster with different colors, while the lower legend on your furthest right shows the type of a second booster with different symbols. The plot shows that most of the primary series first boosters and second boosters are with an mRNA vaccine, and that a second booster offers protection ranging between 60% to 95% against severe outcomes. We're not showing you this plot in the same way as we showed you the previous plots because we have less data. Next, please. All right, so now to the third question on what is VE against XBB. Next, please. Before we jump to answering this question, we want to give you an overview of the VE studies on XBB as of to date. So this graph shows the number of VE booster studies against XBB per month and cumulatively. All the studies are from high-income countries, and the majority of them are studying mRNA vaccines. And to remind you, until now, we've only showed you data with absolute VE estimates, but going forward with the XBB question, we will mainly show you data based on relative VE, as the majority of the XBB studies report relative VE, meaning that the reference group will be those who are less vaccinated. Next, please. So this plot here shows us the relative VE against XBB within 4 months after a first to fifth booster. To remind you, on the y-axis, the plot shows the individual studies, and here you can see them because the plot is less compressed at this stage. And on the x-axis, the plot shows VE. On your furthest right, the plot shows the different outcomes. Because this is a newly monitored subvariant, we're showing you VE for all outcomes. So the upper part of the plot shows VE for severe disease. The middle part of the plot shows VE for symptomatic disease. And the lower part of the plot shows VE for any infection. Mind you that the symbols are the relative VE estimates and the horizontal lines are the confidence intervals. So the coloring represents the different study vaccines. These studies here are selected because they report relative VE over several time points and either report XBB-specific VE or are conducted during an XBB dominance period of greater than 50%. So eyeballing the results, most estimates lie around a moderate additional protection of about 50% to 60% against severe disease and symptomatic disease, with 2 outliers of 90% from the same study, though VE is slightly lower for symptomatic disease than it is for severe disease. When it comes to any infection, one study suggests no additional protection, while another study suggests low additional protection. Most of the study vaccines are still bivalent boosters, but we want to highlight 2 studies where the vaccine type is different. Next, please. One study reported on the ancestral monovalent booster against severe disease and symptomatic disease in Singapore. Next, please. And another study reported on the adjuvanted monovalent beta variant protein booster against severe disease in the UK. The estimates from both of these studies reporting on different vaccine types echo the results of the bivalent mRNA boosters that we see in the plot. Next, please. So there are few VE studies that report on VE against XBB by subvariant. The methods on the left show that this is a study from the UK among adults reporting on a bivalent BA.1 vaccine versus the ancestral monovalent vaccine. And the results on the right show that the study suggests that boosters offer a somewhat similar low to moderate additional protection against hospitalization related to XBB 1.5, BQ1, and CH1.1. Next, please. There are also few VE studies that report VE against XBB over time. The methods on the left show that this is a study from the US conducted among adults and reporting on a bivalent vaccine versus being unvaccinated against severe disease over time. The results on the right suggest that a booster's moderate protection wanes over a 6-month period and more so against hospitalization. The study is suggesting lower VE against severe disease than what we observed earlier during the pandemic. And although there could be several interpretations of this, like Danny mentioned yesterday. One of them is, of course, that the vaccines could be less effective against XBB severe disease, but it could also be that the unvaccinated group has more prior infection and more recent infection than the vaccinated group. And it could also be that the hospitalization represents SARS-CoV-2 infection exacerbating underlying diseases rather than hospitalization being due to SARS-CoV-2 infection. As we know, the vaccines don't protect much against infection. Next, please. And then we're almost there. Nevertheless, this study here helps us interpret what's going on with severe disease. So it's not a true VE study, but it does provide information on protection against XBB severe disease. It's a case-only analysis where SARS-CoV-2 confirmed infections are included and an association between vaccination history and the risk of progressing from infection to hospitalization is measured. The table they show has our ratios, so the inverse of VE. So the lower the point estimate, the higher the VE. This study here suggests that a first booster and more than a second booster reduces the risk of progressing from SARS-CoV-2 infection to hospitalization with 54% and 70% respectively. We find that this case-only analysis this study is valuable because it assures us that the risk of progressing from SARS-CoV-2 infection to hospitalization is lower among vaccinated compared to unvaccinated, even in an XBB context, and in a population where the majority is vaccinated with the ancestral monovalent mRNA vaccines. Next, please. So to sum up the answers to the 3 questions posed, what is VE over time? So VE is consistently restored for a first and second booster to the protection level of primary series. It's highest against severe disease, and it's waning slowest against severe disease. The second question was, what is VE by vaccine? And the mRNA vaccines offer high protection as primary series first booster and second booster. The third question was, what is VE against XBB? And the boosters, they seem to offer moderate additional protection against XBB severe disease and symptomatic disease. This may be somewhat similar to other subvariants, and it does suggest that there is waning over time. Next, please. So thank you to our colleagues at IVAC, at Johns Hopkins, for conducting the Living Systematic Review, and thank you to CEPI for funding the Living Systematic Review, and thanks to everybody for your attention.
Thank you, Anshu. Thank you so much for this global data and update. So we will have our last presentation by Dr. Rashid, the experience from Morocco. Yes, please. I mean, if you wish, also, you can share your slides.
Good morning, everybody. I would like to thank you for the invitation to share with you our experience in Morocco. I'm Rashid Razin, and I'm a professor of public health with my team, Majdurin Obtel, Jihan Blayashir, Ridwan Abouqal, who are also professor in the University Mohammed V in Rabat, Faculty of Medicine and Pharmacy. To start, I will talk about the epidemic situation in Morocco. Until November 8, 2023, in Morocco, there was 1,277,461 confirmed cases of COVID-19 and more than 60,000 deaths. A total of more than 55 million vaccine doses have been administered. Significant decline of new confirmation and deaths. Serious cases treated in intensive care still decreasing, and continued decline in detection activities. Since the start of the pandemic, Morocco has experienced essentially 3 epidemic waves, corresponding to 3 periods of appearance of variants of concerns. The first one from February to May 2021, corresponding of circulation of the Alpha variant. Wave 2 from July to September 2021, corresponding to with dominance of circulation of Delta variant. And third one around January 2022, circulation of the majority of Omicron, 70%. In Morocco, the vaccine strategy was based on, was supported by a national scientific committee for COVID-19 vaccine strategy, who was created by, recommended by the High Instruction of Morocco and Ministry of Health. And all decision was based on scientific evidence developed by this national committee, scientific committee. They developed some guideline, and to support policymaking, this committee anticipated possible vaccination online by taking into consideration vaccine characteristics, the target population, which population will be prioritized, logistic capacities deployed for the vaccination campaign governance and process management. And about the guideline principles, the vaccination campaign were based on equity, volunteering, solidarity, transparency, and it was free. On January 2021, Morocco launched the vaccination campaign for COVID-19 vaccine deployed in Morocco, Pfizer, BioNTech, Johnson & Johnson, Oxford AstraZeneca, and Sinopharm. In January 2022, there was 70% of target population who was vaccinated, and 72% was vaccinated by Sinopharm vaccine. In this time, limited data on the real-world effectiveness of inactivated COVID-19 vaccine was exist in this time. For this, our team, in collaboration with the Chinese team, conducted the first study. It was a real-world study of the effectiveness of Sinopharm COVID-19 vaccine in the Kingdom of Morocco. We conducted a retrospective cohort study among adults between 19 between 18 and 99 years old were tested by RT-PCR for SARS-CoV-2 infection between 1 February and Jan 30, 2021. RT-PCR results were individually linked with outcomes from the COVID-19 severe or critical hospitalization dataset and with vaccination history from the National Vaccination Register. Individuals with partial vaccination less than 2 weeks after dose 2 or in receipt of any other COVID-19 vaccine were excluded. So we explore only Sinopharm, effectiveness of Sinopharm, because it was the most widely used in Morocco. And adjust VA estimate against hospitalization for serious or critical illness were made by comparing 2-dose vaccinated and unvaccinated individuals in logistic models and calculated vaccine effectiveness. In this flow chart, we have the number of participants from 1 February 2021 to 30 Jan 2021, a total of 400,030 and 438 record from the COVID-related severe of critical hospitalization. Data sets of ELAB were able to be matched with vaccination history in the National Vaccine Registry. After exclusion of missing data on sex or age, administration of a vaccine other than Pfizer-BioNTech, and partial vaccination, 348,180 record remained and comprised to the analytic dataset. In this table, we show the vaccination status of subjects by sex and age group. Among subjects, there were more men than women in the population. More younger people than older people. For example, 29.9% were between 18 and 29 years old, and 9.9% were 60 years or older. There were 206,149 individuals that represent 59.2% of subjects completely unvaccinated, and 40.5% individual fully vaccinated with 2 doses of Sinopharm, and 0.3% individual who received booster dose. So a small number of persons received booster dose. Here we have the result and adjust vaccine effectiveness by sex and age group. And adjust vaccine effectiveness against serious or critical hospitalization was 90.2%, and significantly. After adjusting for age, sex, and calendar day of RT-PCR test against serious or critical hospitalization was 88.9%. Adjusted the VA was higher among female than male, and higher among individuals less than 60 years than individual 60 years and older. It was between 96.4% versus 53.3%. So effectiveness of Sinopharm's vaccine was consistent with phase 3 clinical trial results. 2 doses of Sinopharm was highly protective against COVID-19 associated serious or critical hospitalization in working age adults under real world conditions, and moderately effective on older adults. We have some limitation for this first study. There were no analysis of virus strains and VAs against specific SARS-CoV variant could not be estimated. According to the WHO report, more than 90% of SARS-CoV isolate were alpha variant in Morocco in April 2021. Thus, the VA estimates are mainly against the alpha strain. We leaked data on comorbidity and other characteristics of the study population that could influence VA estimates, precluding controlling for potential confounding factor other than age, sex, and calendar date of RT-PCR testing. We did not have data on reasons for severe or critical hospitalization. As a result, our study could not distinguish hospitalization caused by SARS-CoV-2 infection from hospitalization coincidental to this infection. The timing of the study was such that too few individuals had received booster doses, precluding robust analysis of Sinopharm booster dose vaccine effectiveness. The second study was a long-term effectiveness of inactivated vaccine, also Sinopharm, against COVID-19 associated severe or critical hospitalization in Morocco. Of this time, we will evaluate the vaccine effectiveness about critical hospitalization. We conducted a test negative case control study among a population aged 18 years or older who were tested by RT-PCR from SARS-CoV-2 infection from February to October 2021 in Morocco. From the National Laboratory COVID-19 database, we identified cases who were RT-PCR positive among severe and critical COVID-19 cases, and control who had a negative RT-PCR test for SARS-CoV-2. From the linkage between data from the National Vaccination Registry, individuals vaccinated with COVID-19 vaccine. So this register, we have information about person who was vaccinated, the date, the dose, and the type of vaccine. And those unvaccinated were identified and included in the study. The linkage between database was conducted for the study of vaccination study based on the timing of the vaccine received relative to the SARS-CoV-2 RT-PCR test date. For each person who tested positive for SARS-CoV-2, we identified a propensity score matched control participant who was tested negative. We estimated vaccine effectiveness against SARS-CoV-2 severe disease against hospitalization using a conditional logistic regression. First result among 12,000, more than 12,000 persons who test positive, and 12,884 persons who test positive, and 12,885 control participants. The median age was 62 years. We identified 25,076 matched pairs of patients who were tested for SARS-CoV-2 infection between February 1, 2021 and October 1, 2021. The median age was 62 years among those who tested negative and 63 among those who tested positive for SARS-CoV-2 infection. In both groups, 47.2% of participants were female. Among those who tested positive, 1,015, 7.9% had been vaccinated. And among those who tested negative, 22.9% had been vaccinated. Here we have the result about evolution of the effectiveness. So in the right, Our results showed that the effectiveness of Sinopharm vaccine against severe COVID-19 associated hospitalization reached a maximum level during the first month and remained high and durable during the 3 months after the second dose, between 87 and 90%. Declined little in the 4th month, 75%, and stabilize around 60% beyond the 5th month. And on the left, we have the difference between older and less than 60 years old. Vaccine effectiveness remained high and stable during the first 3 months in the 2 age subgroup. In the 4th month, the VA in the older population, aged 60 years and above, 64% was reduced by 20 points compared to VA in younger population, who is 84%. Limitations. In this study, limitation will include looking only at critical care hospitalization as outcomes. We did not estimate the effectiveness of the vaccine against other outcomes such as symptomatic infections, hospitalization, organ injury, or death. We primarily investigate the severe and hospitalized COVID-19 cases, which are a better indicator of vaccine effectiveness for public health relevance. Second, we adjust for factors such as age, sex, calendar days of the RT-PCR test, geographic location, and the 7-day moving average of the percentage of SARS-CoV positive tests. But we did not account for other factors that may have influenced the outcomes, such as obesity, comorbidity, smoking, and clinical data, because we have not this information. Challenge and lessons learned. These studies confirm that Sinopharm vaccine in Morocco is highly protective against SARS-CoV-2 in real conditions. Also, the durability of the protection. VI depends not only on the effectiveness of the vaccine itself, but also on factors such as essentially the age of the recipient and time since the latest dose. The elderly population is more vulnerable and at greater risk of immune depletion over time after full immunization, and deserve special attention. Therefore, maintaining the stability of their protection through either continued social distancing and active vaccination, such as boosting, must be a priority. Thank you.
Thank you so much, Dr. Rashid, for the experience from Morocco. So I was just thinking that, it's good to discuss also because, for example, the results of Morocco study that shows that, for example, Sinopharm has positive vaccine effectiveness. This is a bit different from the results that we receive from our other studies in the region, but somehow similar to what, Paho, you explained. So I was just thinking maybe having some kind of meta-analysis to just put together all this data will give us more valid data about the vaccine effectiveness of these kind of vaccines for COVID-19, but this is just for discussion. So we had different presentations about knowledge research management pillar during in WHO during COVID-19, as well as our update regarding surveillance system in EMRO. We heard from Anshu about the global data, and also from Dr. Rashid about Morocco experience. So now I just want to announce the time for discussion and question and answers. So floor is open for discussion. So as usual, as we did yesterday, please just put upright your name stands or raise your hands for online colleagues. Thank you. Dr. Lace, please.
Yeah, so it's actually regarding Arash's presentation, which is really very nice, and it's great to have this big picture. In relation, however, to the governance, you presented a very good point about inadequate governance in some places, but we are actually running into problems with too much governance in other places. It has become very difficult sometimes to do epidemiology research because we have so many different approvals, so much bureaucracy. The system is not being able really to function effectively to allow actually smooth process. And in the process, and as a result, actually, many times we had to stop studies because we are unable to do so. Sometimes even we lost our funding to do projects because of actually the challenges in this governance. It's very, very complicated because often we don't need only approvals from one entity. We need multiple entities at the same time, and which makes it really impossible when we have too much bureaucracy. So I worry a lot, honestly, when we talk about governance, because it's really dangerous. When we say we want to improve governance, we end up usually putting so many barriers that makes it impossible to do research. I have had horror stories in the 2 decades of doing epidemiology research in the region, just because of that, yeah.
Please, Dr. Fatima, and then Dr. Najafi.
Thank you, Dr. Krandish. My question is for Dr. Amal, which I thank for your presentation. My question is regarding the genomic sequencing and genomic surveillance, and how to integrate the genomic surveillance into our SARI and ILI surveillance system, not only SARI and ILI, but also EBS and IBS. You mentioned the integrated disease surveillance in a sustainable way, and the need to link the result of genomic surveillance with our EP data to guide our response.
Dr. Najafi?
Thank you for all presentation, and thank you from Dr. Rashidian for presentation about the knowledge translation and how we can translate the knowledge to the policymakers. My question is, yesterday there was a suggestion that that would be a good idea to provide a brief policy for each country regarding to the result from Iran, from Pakistan, Jordan, and other countries about the vaccine effectiveness. This is a good idea, but probably the best idea would be putting all this information within one policy brief by EMRO and then distribute it to the countries. I think that would have more impact on the decision making within the countries. This is the first point. The other point is, even before trying to translate the knowledge to the policymaker, is that would be a good idea to harmonize all the point, even details about the analysis of data. For example, I saw the presentation from Morocco, and they excluded vaccinated people, those who get vaccinated further than 2 weeks before hospital admission. So we did the sensitivity analysis. We didn't observe any differences between inclusion and exclusion, but these detailed points need to be addressed by all study sites. Thank you.
Dr. Zia?
Yes, it's from Dr. Amal. I run a public health reference laboratory at my university, in Cairo Medical University, Peshawar, Pakistan. So established this in 2015. Nobody was recognizing it. They said, what is public health lab? But then COVID came and everybody was recognizing it. But when again COVID finished, the government is going back. So even the WHO office, I wrote so many emails. There's no support from the WHO office for the public health reference laboratory, and we are losing there. So I think this is like when the pandemic is over, it may not be the last one. So this is the time to tell the country offices to really strengthen and make this, do not die, this public health reference laboratory network, which we established in this.
Dr. Arash, and then Kamal, and then Dr. Nabi.
I understand there are questions that I need to address, but now this is for my question.
Questions, yes, then we'll go to.
Yeah, no, sure. I'm following the process. So my question is actually to Anshu, and with the presentation about, I mean, the sort of living systematic review and the updates with the ongoing vaccine effectiveness studies. So, I mean, in a similar, you might have done this, Anshu, but I mean, sort of, and if done, I mean, I'd like to know the answer, and if not, would be it's a proposal to do that. So when, for example, we do systematic reviews of effectiveness studies, one of the questions that we try to address or try to propose in the end, when there are many large-scale studies coming in, is that whether what additional evidence might change the outcome. So, I mean, let's say, given the picture that you provided, which was very much consistent, I would say, I mean, to what probably we got to know after 2 years of, I mean, such studies. So how large a vaccine effectiveness study with a different outcome should be to affect the result of the meta-analysis? And on the other thing is that, I mean, you highlighted a few things, and we've done that also in this discussions in the regional office when planning the support of, I mean, the surveys and vaccine effectiveness, the follow-up rounds, is that what would be the key questions that the new studies should address? I mean, given that, I mean, this is coming. Obviously, we are discussing some of legacy studies now that have been conducted in a different context, but I mean, for future next steps. So what, based on the systematic review, what are the key recommendations for the next steps?
Yeah, thank you very much, Manaz. And thank you very much, Dr. Arash, for your vision for what will be the next step to leverage on the work which has been done. And I have been discussing with Marnaz that we might have a kind of collecting more analysis and more data to do a meta-analysis for the already done presentation to have a larger picture of the regional perspective. And this is actually a very good point to start with. Actually, I have a question for Amal and a question for Dr. Rashid. Amal, it's very nice to know now that the platform is hosting the three etiological agents, but I would like to ask you if there is a kind of perspective, knowing that the respiratory syncytial virus vaccine is coming very soon and it's gaining a global interest right now. Is there any thinking to include this in the surveillance system as well at the global level as well as the regional level? My question, Dr. Rashid, thank you very much for highlighting these very important actually studies that have been done by Morocco. It was very interesting to me. I have actually a question related to the second study related to the critical and severe hospitalization. You have mentioned in one of the limitations that you didn't include all the comorbidities because of the lack of data. So this is something, would you be kind enough to explain it, how you don't have this data, though you have the patients hospitalized and all clinical data with comorbidity are there? So was there any maybe further analysis to this data which is available to include those comorbidity, looking at other factors than COVID? Because in this study, we have seen that the vaccinated in the tested negative are 3 times the vaccinated in the cases, which gives a strong preliminary data on vaccine effectiveness. But it would be much appreciated if you also include some other co-founding factors, especially the comorbidity. Thank you.
Thank you for the interesting presentations all this during this session. And my I want Dr. Arash to clarify to us what's the link between the WHO and the governorates, how to make this results applicable to, for all countries, to the governorate or the decision maker or the decision policy. Because I have previous experience just having results and nothing else. Thank you.
Thank you so much. Thank you. So any more questions from also colleagues online? Oh, okay. So sorry, somebody, please.
So many thanks for the rich presentation. Non-original question for Amal, which is we stemmed out also from the gains on COVID-19 promoted by the emergency department. It's specifically on the sustainability of genome sequencing. If some, solution from a governance level, also from a finance level was crafted to ensure the sustainability, especially in low-income countries in the region. And then governance, which is a question for all of you, I believe, because there is more and more investment in these public health institutes, agencies at the country level in the region. We have the GCC one, but also we have, for instance, the JCDC in Jordan and many others like Libya and so on. So I think there is a need of brainstorm on how to address this. I just received, for instance, an invitation by WHO headquarters on a discussion about this public health institute that could be maybe the right place for certain aspects on public health, like pandemic preparedness response. But of course, it's very context related. But this deserves a very much important discussion on how to address the policy making. Thank you.
Okay, thank you so much. I cannot see any names stand, up right here. Any colleagues online? No further questions, comments, suggestions? Why? Okay, so let's start with the answers. If you
next to Zahra's name.
this is I think the most
okay.
okay, the hands are in yellow usually. So so let's start with the answers to the questions. So we have quite number of questions to the speakers. So let me start based on the order of the agenda. So Dr. Ash, will start with you, please. Thank you.
Okay, many thanks. And I resonate with what you say. I mean, sort of, I'm personally proud of my researcher background and done a lot of research. I've been sort of on the recipient end of the governance procedures. And I also am aware this is not a concern just in our region, it's also globally, sort of our governance, our sort of regulation, etc. So that's a challenge. That's something that is not less important. But the picture that we saw during the pandemic was really showing a real big gap. And that needs to be addressed. What would be the best way to address it? That's the question we are going to answer in consultation with the experts in the region, in consultation with the country. So this is part of the discussion we are going to have in the the consultation is starting from tomorrow. So that's where we are going to have a focused approach to that issue. We had a meeting of the National Research Ethics Committees in Muscat recently. And part of, actually, I raised the question of these studies to colleagues there. I said, you are the guys in charge. And this has happened under your watch, basically. What's your reaction to that? So the reaction was quite varied. Some colleagues, they said, well, you are, so we shouldn't extrapolate the conditions of a pandemic to other conditions. It might be true. There were other colleagues saying that it's not actually our responsibility. There are certain things are not within our mandate. So in a way, within our mandate, we actually see what comes to our desk. We cannot talk about what doesn't come to our desk. So there are real regulatory processes there. And, but there are practices that definitely are not acceptable. And varies from country to country, varies to context to context. So in a way, I think what I totally agree with you is that the message should be in a way that it will not become a sort of one-size-fitting-all. So should be considering all those concerns and then how to balance those together. So on the sort of regional policy brief, obviously, that's a good point that you raise. That's something I'm sure Mehnas has been thinking about, and so will be part of the discussion. And perhaps it's linked to the question you raised. In the afternoon session, as part of the, because there will be colleagues from national immunization technical advisory teams, the NITAGs, and also the regional immunization advisory group, RITAG. So they who are dealing with the policy making for related to vaccination. But then there will be also, I mean, some small discussions from my side and Mehna's side. We will talk about the regional agenda to enhance use of evidence in policy making. So there are big challenges there, but there are work that is happening. So I guess perhaps we can have that discussion in the afternoon and taking it forward from there.
Thank you, Dr. Arash. So Amal, you have numbers of questions, please.
Yeah, I didn't know. It's very, very important. So we'll start with Fatima. I mean, your question is how to include the other surveillance system, I mean, event-based, zoonotic, I mean, to sequencing. I will rephrase it in maybe another way. It's how to use the sequencing and the genomic surveillance and include it to the routine surveillance, because sequencing is a tool. What we have seen during the COVID, that everybody was sequencing and just putting in the gene bank and decides thousands and thousands and thousands of sequences without any logic, without any and nothing. And this by everyone. I mean, you go to the countries and you see that all universities, I mean, I understand that universities, you are doing a lot of research and you need publications. But
Amal, I know that you have called, but if you can just come closer to the mic, or sorry.
It's okay now? Yes. So I said that during the COVID, what we have seen is that a lot of resources, a lot of people sequencing, doing the sequencing, but this sequencing without no logic. I mean, we couldn't even, without any metadata, and the objectives, I mean, for routine, for genomic surveillance, it's really to help the public health actions. This is what we really need to, and this is our objectives. I mean, we want the genomic surveillance to be integrated in the routine surveillance, whatever routine surveillance. I mean, for flu and the respiratory, I have put the algorithm. We have the GISers have put for the lab. All the labs, this is how they need to function. I mean, if they have the capacity, maybe they can go beyond 150, but we really need them to have meaningful surveillance. We need them to test something like from 150 to 150. And from these, they need to sequence 15. It's more than sufficient for us to understand the variability and to monitor these pathogens. I know that polio, they have their own objective. TB, they have their own objective. It's surveillance have in all objectives. And this is what we need to include in the routine. So governance. It's how to put all these people who are working, I mean, in one, and to avoid the duplication and waste of resources, because this is what we really need to avoid. It's really these people need to work as a consortium, because here we are talking about public health. Public health, we need results, we need data for public health actions. We're not talking about. So this is what our strategy, I mean, the regional strategy is for. I mean, we have the regional strategy. We know how we are supporting the network to be able to have actions, data for actions for high-threat pathogens, because we are expanding to our priorities. But we are asking the countries, I mean, to really set up this consortium and to put all these people in one table and to discuss how they really want to work together. From Jordan, I mean, I'm receiving requests from many, I mean, labs and the surveillance department, I mean, to support them. We cannot support everyone. I mean, we can, because if you are sequencing for flu, the other are sequencing for flu, what is the main objective? To sequence all of us. I mean, of course, again, I said that this is different than research. We are talking about public health. I don't know if I answered your question or no.
Actually, that was my question, how to use the sequencing result. First, how to integrate and include them in a sustainable way,
Yes.
and how to use these results to guide the response?
Again, it depends of each program, but if we have to include the genomic surveillance, it's very easy. I mean, we know how to use it for flu and for MERS. For MERS, we need to sequence every single positive samples because we don't know the disease yet. This is why we are supporting the countries to support all the MERS positive samples. For flu, we don't need this to sequence every single positive sample. So this is what I'm saying. I mean, for cholera, we need to confirm, I mean, and we need to break the transmission. So this is why we are sequencing, and it has its own method. So every program has the objective for why we are sequencing. So this is why, I mean, every program needs to sit together and we need to sit to fix the objective. We did it for flu, we did it for MERS, we did it for cholera, we did it for CCHF, Crimean Congo now. So we are expanding it based on the priority diseases. So this is where we are going. Public, I know, I mean, we have said that during the pandemic, I mean, the government, I mean, each countries, I mean, build this big network, which will never be able to sustain. No countries in the world can sustain this big network. So this is why we really need to be realistic and go back to what is the right size. Each country needs to be able to support this kind of surveillance. It's not about the country office, unfortunately. It's about the countries, about the ministries of health. I mean, we are asking them we are supporting them, working with them to really put what they have now, what they gained with the COVID. Of course, it's really unfortunate that we will just lose. This is what happened during the H1N1 pandemic in 2009. I mean, we lost everything. So we don't want to have the same case. I mean, we are really working with the countries, I mean, to sustain the network, any network, but network that can be sustainable by the countries. I mean, as a partners, as a WHO, we cannot pay the operational costs. This has to be, we can help. Each network can help, but this is the country's decisions first.
Yeah, I'm saying that I was in WHO at that time in which we see this bird flu in KP, the first case. We are doing the same again in 2020. So I was part of 2009 when pandemic came. So we started from the same. So I'm just seeing that at least like 240 million people in Pakistan now. So at least we should have 4 labs in each province. We should have at least 1 lab. So the WHO, you know, when something happen again, so WHO will start again. You know, if you leave it to the government, you know, so like keep pushing them and sending them. At least they should have 1 big lab, and they should send routine samples there. So I think we really work hard during this COVID 2 years, and it's going away from us. So that's why I mentioned this.
Yeah, fully agree. The question about the RSV, yes, the network is really supporting the introduction of the RSV vaccine. We are piloting in some countries. I mean, each region is piloting in some countries. Here it's 5 countries, but the only one who really I can say that are part and have generated a lot of results is Egypt. So now that the vaccine is almost ready, they still have a lot of issues with the age 0-6 months. This is why the piloting now is targeting this age group. But I think a lot of Gulf countries and the countries who are really have the capacity. I mean, we are supporting them to start. I mean, the RSV surveillance. It's not easy. I said that we piloted in 5 countries. Only Egypt could do it because you really needs to have a different sentinel site than flu. You have to use different case definition, and it's not easy for a lot of countries. I mean, You change case definition and you get about, you are in trouble. Use the same. This is why, I mean, we are working hard, I mean, to really fix the case definition for all the priority pathogens.
Thank you, Amal. So there was no more questions for you. So, I mean, we are a bit behind the schedule, but, because of the great discussion, I didn't want to interrupt. So please, give, answers, a bit faster. So we have one question to Anshu from Dr. Arash.
Yes, thank you, Dr. Arash. I'll try to make it quick. I'll start with a question that I remember the clearest, which was quick questions that new studies should address. It's a good question. From a policy perspective, the interest still seems to be on new subvariants, interval between boosters, and new vaccine platforms, and new COVID-19 formulations. So that's one part of the puzzle, right? And then the other part is, what are we reviewing systematically? At this stage, we're not really changing much in our inclusion criteria overall. It's important to look at them and then see to what extent the studies can address them, such that they do get included in this systematic review. A few things that sometimes are not included in these studies and then end up being the exclusion reason is if they're not adjusted for age or calendar time, and if there's not clarity on the time since a last dose in both the vaccinated groups and the less vaccinated groups. It's tricky indicating the information on previous infection, and we haven't quite landed there yet, how to address that. But really the key message would be to keep, to the extent possible, adhering to the inclusion criteria that are existing. And then I'd like to echo Daniel's points from yesterday, getting into the interpretation part of the studies, keeping a closer look at the epidemiological context to see if there is this connect or disconnect, like he mentioned, in the context of us potentially observing lower VE against a severe disease. If that's really the case, then is that reflected in epidemiological data? Are we seeing more spikes in hospitalizations, for example? And then another part I would add would be the case definition. It was mentioned earlier, I think, to tighten that up, or use opportunities if there are to tighten those up. Example given with using ICU, or the use of oxygen, any kinds of ways that you can indicate the severity, such that it will be easier to tease out what the outcome really is. I'm not sure, Danny, if you have anything to add. And I think Dr. Rush, you had another question too, but I didn't quite get that. So if you could repeat that, or we could take it offline also. Happy to do that.
Yeah, just quickly, I mean, and the discussion could be later on as well. So I mean, roughly speaking, is that, let's say, so I mean, I don't know how many cases now are within the systematic review. Obviously, with the context, with the vaccine, etc., the timeline, then that number is different. But let's say, so for Moderna vaccine, you have already so many cases related to Omicron, so 500,000 or I don't know, 100,000 people already within vaccine effectiveness studies are studied. And there is an effect, which is this point estimate with this confidence interval. What should be the size of the next vaccine effectiveness study for Moderna on Omicron to significantly change the point estimate of effectiveness that you have right now? So in a way, I'm talking about the value added of the next study. So is there any indication for that, or is there any meaningful, I mean, the value for such a proposition to guide future studies?
So you're talking about increasing the sample size, or what we would expect to see in terms of the VE estimate going forward? The latter. Yeah. I think Danny would have to jump in, but my take on it would be that that's difficult to say, but we are seeing studies more and more with negative VE estimates. And there'd probably be lower VEs overall that we'd see, because the differences between the vaccinated group and the less vaccinated groups are getting smaller and smaller with the prior vaccinations. So the guesstimates would be that we would see lower VEs overall. The absolute VEs are generally higher than the relative VEs. So it's difficult to say at this stage what they will look like, because we also have these negative VEs in the middle of these things. So we have to see overall what the picture looks like, but probably they'd be lower. Danny, I don't know if you agree on that.
Yeah, I mean, I think if I understand your question, Dr. Rashidi, and I mean, for most of these vaccines, we have a lot of studies now. So it's hard to imagine that one study would move the needle somewhere else for a vaccine, even a big study. But I think that the point is that things, as we know, with COVID change very rapidly. So I would say a study that has a different result would be more reflective of a change in the virus and the vaccine's protection against that virus in the setting of hybrid immunity and waning, rather than sort of trying to clarify how that vaccine really, what's the truest VE. I think what's happening is we're seeing changing epidemiology. And I also wanted to bring up the point that I heard as part of the general discussion. I'm glad to hear that some of the sites are now expanding to include other viruses and trying to envision this more as a sort of a multiviral pathogen platform that can do VE studies, not just for COVID, but for influenza and RSV. I will say that what we saw during the pandemic is that we saw certain sites that had very strong platforms that were always the first to deliver VE results when things changed in the pandemic. So if it was a new variant, if there was waning, there were always a few sites. One of which was Lath's site in Qatar. And to me, what that shows is that there is a value in having a platform that's ongoing when you're having a pandemic or even a disease that's changing a lot. And you know you're going to constantly need vaccine effectiveness as things change. The hard part is getting the platform up and running. And I think we saw that in some of the presentations. It's a lot of work. It really is a lot of work. That first one you do is going to be much more work than the second, third, fourth, and fifth. So I really hope that some of these platforms that were set up in your region to do COVID vaccine effectiveness will be able to be sustained, both for doing VE for SARS-CoV-2, because we're not out of it completely yet, but also for other viral diseases. I mean, having a platform in place ready to go is really key. Thank you.
Thank you so much. So there was just one question also from Kamal to Rashid yourself, please. Thank you.
Thank you, Dr. Kamal, for the question. About the information about comorbidity, we couldn't use it because we extract information about COVID-19 associated severe or critical care from a data set, a minimal data set who was made only for surveillance of cases of hospitalization cases. So we haven't information about comorbidity like diabetes or like obesity. So we couldn't do. So the information was extracted from a data set of national surveillance. And we have not a clinical sheet or information from clinical sheet.
Thank you so much. Thank you. It was a great session, really, and a very excellent discussion. Okay. Hi again, colleagues. Hi, colleagues online. So we will continue our session with a topic on statistical analysis considerations for estimating COVID-19 vaccine effectiveness. This session will be delivered and moderated by MMGH Consulting Company, epidemiology company. So we will have Manuela Thomas and Carsten, who will present this presentation. So we will start with Manuela. Please go ahead.
Yes, thank you. Hi, everyone. I'm presenting on behalf of the team and then together with Thomas and Carsten, who are also on the call. And this just to set expectations in the beginning. So here I'm providing some refresher on things that we already discussed on day one and also this morning on some of the important consideration when doing an analysis, interpreting results, and especially using them for policy making or policy decisions, and going less into statistical details and methodology there, and then afterwards open up for discussion. So this presentation is divided into 3 parts. First, talking about these what we had yesterday about general challenges, specific challenges, and unique challenges, how to consider them when performing a statistical analysis in CVE studies. And then in the second part, which I think is highly anticipated, so some questions came already this morning and yesterday about combining VE estimates for more robust evidence. And then the third part, which is presented by my colleague Thomas Schirian, who's on the call, for considerations when interpreting results for informing policymaking. So at the beginning, some slides to set the scene. So that might be repetitive since we already discussed it a bit yesterday. So we had already seen yesterday and today that the COVID-19 pandemic is like a constantly emerging situation, and that's why we need observational studies. So on the right, we have this varying vaccination scale up over time across countries, the emerging variants. So this is just, again, to highlight all these challenges that make it difficult to provide robust and reliable estimates on vaccine effectiveness. So the advantage of observational CVE studies is that to provide real-time data and real-world evidence on the effectiveness of vaccines for different populations, different variants, and all of these different vaccination strategies, combinations that are happening in practice that would not be feasible to do with clinical trials. However, since they don't have this randomization, they're prone to bias and confounding, which is then some part of this presentation. See an overview of the different factors, so not diving there into the details. I think that most of these concepts are familiar to most people in this room. So there's different things to consider when planning a study, when conducting the study, and then when analyzing the study. So just to highlight here a few points, and when thinking about a sample size, so you all have done this WHO sample size calculator. Once this is then done and the study is conducted, there's no adjustment for it in the analysis for the specific study. So that's probably also why the pooling came up to then strengthen across different studies for more robust estimates. And then also for bias, this needs to be taken into account in the design of the study with careful definition of the inclusion and exclusion criteria for a study. There's no correction for it in an analysis per se. One can do sensitivity analysis, some interpretation to try to understand what's happening, but there's no correction for it. And then 2 things that I'm not going to talk about today, but also important considerations are missing values and loss to follow-up. I think especially the 4 countries that were presented yesterday did a great effort on reducing missing values and follow-up, but it's still always for any observational study important consideration, and then whether doing a complete case analysis or doing imputation, and then it can be tricky to make sure that there's no new bias introduced. So the main part is then the confounder effect modifier. There might also be other terms like mediator or collider. So not driving there into these differences, but any confounder that might bias the results in the vaccine effectiveness that needs to be taken into account. So importantly, these also need to be thought of when planning the study to be able to observe them in the study. Otherwise, there might be the risk of residual confounding. So yesterday, we also heard that around 50% of the CVE studies are cohort studies, mostly in healthcare workers, and around 50% are test negative control designs where the SARI platform provides a convenient platform that can be leveraged for this type of study. And here it's just depicting these main characteristics across these 2 study types. And then here for a cohort study, it can of course be, it's usually prospective, but we have also heard examples of retrospective cohort studies. And then advantage is that it also provides incidence estimates, and it's usually less biased than, for example, TND studies, but it's very resource intense. So it requires large sample size. It requires good selection of the sample where you can be sure to follow them up for 12 months to reduce loss to follow-up. And then for the test negative design, I think there's a recommendation say around at least 6 months follow-up, but we had also longer time for follow-up. And these leverage these existing platforms. So we heard from Dr. Amal this morning, some of these platforms, and also yesterday from the POW study who leveraged this test negative control SARI platform for influenza, integrating COVID into it, and then leveraging this platform. And then this one is reducing this bias due to differential healthcare seeking behavior, whereas it might also have other complications, which I go into the next slide. But in general, this takes less resources and is the recommended design for countries with lower resources. So here's a mix of list for the two study designs again, what to in general consider for these two types. So the cohort already mentioning the centering and loss to follow-up, which needs to be taken into account. And then specifically when looking into healthcare workers, the vaccination coverage might be really high. This might limit statistical power as well, but should be taken into account in the sample size calculation. And then there's also clustering across health facilities, which also applies to this negative design. And one additional confounder for this specific population would then also be in which department they're working in, because the exposure is different across healthcare workers. And then for the TND design, the most concerning bias might there be the misclassification of cases and controls, but again, with careful definition of the SARI definition, and as well as testing protocols, this can be reduced. And yeah, so as mentioned already, it avoids the healthcare seeking bias and reduces selection bias. So not completely, but I come back to that in another slide. And then there's some specific consideration to this design, for example, that controls who test positive for influenza might need to be excluded because a different association with having higher likelihood to have been vaccinated for COVID as well, and some relationships there. And then as we just discussed yesterday, or Dr. Najafi brought up, this secondary outcomes using in a case control study might then need conditional logistic regression, but there's also different options to do there. So this list probably looks most familiar to everyone. Here's just the list of the most common confounders that most studies are accounting for: age, sex, comorbidities, healthcare worker, yes or no, and then if so, in which department. And then these are person-related. There's also study-related factors that need to be accounted for, such as region, to avoid to account for clustering, also hospital, and then most importantly, calendar time, since we talked a lot about this changing situation, changing landscape of COVID-19, not only the disease dynamics, but also testing policies, vaccination policies, and protective behavior, a lot of time varying factors. This can be minimized by including calendar time in the model. And there might be other possible confounders like smoking status or pregnancy that some studies mention or might include or test for. And then here I put some examples from some studies from the EMRO region. So here's one from a case control study in Iran. So just depicting this baseline characteristics as like for illustration, that one in the study, one is having these baseline characteristics, comparing them by the cases and controls, and calculating the p-value to see whether they are significantly associated or different between cases and controls, to justify also their inclusion in a multivariable model. So you have a few more examples on this. This one is the same study now, and it's truncated for one of the tables. So with the absolute VE of AstraZeneca against temporary admission in the general population. And it's looking at unvaccinated against then different vaccination status in this population studied, with the cases and controls. And then here I think the highlighting does not show up, But you see the two columns with unadjusted odds ratio and an adjusted odds ratio, and these are slightly different. So this one is then showing confounding is happening, or the confounders are having influence on the vaccine effectiveness, and it's important to include them. And then you get a more robust result for the adjusted odds ratio. And then the very right column shows the final result, which would be the adjusted vaccine effectiveness. There can also be cases where confounding is less present in a study. So this one is now one from a retrospective healthcare worker cohort study in Kuwait. And they looking at hazard ratios and then adjusted for age, sex, and nationality. And for these three variables, you can see for the last two columns that there's very minor or like negligible differences between the unadjusted and adjusted vaccine effectiveness. So it does not say that there's no confounding, but among those that were observed and included, they don't have any change in the final odds ratios. So then here's an example from a study from TND in Qatar that also was presented partly yesterday. I think there's several publications, and one of them had also resulted in negative VE. So this came also up during discussion again. So this can be a true effect, but it's more likely that it's not a true effect, but some bias or confounding going on. And there's been an elaborate discussion section for that study, which is really insightful as well. And so different explanation could be that there's residual confounding, that there's still factors that are different between cases and controls that were not observed in the study and included in the multivariable model. Or there could be biases. And these are then, for this, one needs to have the epidemiological context of the study, of the country, to be able to say which is more likely. And I think the conclusion there was that it might be a case of depletion of susceptible, explaining this negative VE, that after 6 months, after the second dose, at this time, there were really not many, too many susceptibles, too few susceptibles left, and it was different between cases and controls. So talking about biases, the list is long, and this one is just a small list of the many potential ones, but the most relevant ones that came up during the discussion today and yesterday. So not going there into too much detail, but then for each bias, there's also a method of how to try to minimize these. And for the selection bias, so this can be then again by the definition of inclusion and exclusion criteria be minimized. And then for the collider bias, this might be the case for TND, where this admission to hospital and being tested is associated with exposure and outcome, and then might introduce some kind of selection bias. But then when constraining the outcome to more severe patients, or the selection, the enrollment into the study to more severe patients, this can also be limited. And one, I think more well-known is also this recall or ascertainment bias, which is then related to the next one is diagnostic and misclassification. So there just to highlight that using the protocols of how to ascertain that someone got a vaccine at the date is very important, as well as the testing, like having a disease or not, and then having a PCR confirmed test versus just a recall of being infected or having the disease. This might be less possible for past infections, where it's very heterogeneous across the population, and some people might have been tested, some not, and so on. Some too that came also up in the presentation yesterday is prior infection and spurious immunity. And I have 2 small slides following that one. So for prior infection, there one can do sensitivity analysis and excluding or including those. And then again, it can be tricky depending on how prior infection status was collected in the study. So I don't want to go into too much detail. We already heard about it yesterday, about these 2 biases. So I will skip that one. I want to put a bit of waning immunity, which also came up. And here I found this quote that it's not a bias, but a biological cause to estimate, which I liked. So, and here's also some difficulty with the waning immunity. So this figure shows on the x-axis the days after receipt of the first dose of the vaccine, and on the y-axis the hazard ratio. And then it has these different time intervals, so 7 to 35 days, 36 to 102 days, and then 103 to 181 days, as well as an overall estimate with 7 to 181 days. And it's providing VE estimates then for each specific period or overall. And then, as you can see, and as expected, for the overall period, it's somewhere in between from the specific periods. So both of them provide some value for interpretation. So for some questions, you're interested in the vaccine effectiveness by time since vaccination, and for some, you're also interested in the overall period. However, this might also include some or have some selection bias, because when looking at, for example, the period 36 to 102 days, you're excluding all those that were exposed before to the virus and only including those that were free of infection until then. So there's no gold standard to account for these, but again, it's an important consideration for interpretation of results, especially when looking at specific periods after vaccination or a combined estimate. So another consideration which was highly discussed today and yesterday is the difference between absolute and relative VE. Not so much the difference, but the interpretation. And then putting here again, so absolute VE is a comparing of the frequency and outcome in a vaccinated versus unvaccinated group. And then for relative VE, so there I like the terminology that Anshu used was about vaccinated compared to less vaccinated, because it cannot be clearly restricted for a booster to primary series, but there might be other combinations. But then it's relative, so it's not compared to unvaccinated, but less vaccinated. And I just want to skip here to the illustrative example. So in general, looking at the relative vaccine effectiveness alone can be misleading, because it's relative on the vaccines that have been received before. So here's an illustrative example from this study by Lewis et al., who has done a scenario case analysis for vaccine A. So it's a hypothetical scenario to demonstrate this. And then there might be 2,000 people or 2,000 events that if there's no vaccine, all of them would be infected or having the disease or severe outcomes. And then with the vaccine, 75% of these are prevented. And then when adding a booster to this, there's a 250 cases additionally averted. So it's around 50% of the remaining ones that were averted. And this gives you a relative vaccine effectiveness of 50%. There might be the case for vaccine B, where you again have starting off with the 2,000 events happening that were, if you had no vaccine, and then if you have a vaccine that as a primary sequence only prevents 25% of the cases, it could still be that the booster gives you an estimate of 50% relative effectiveness, because it's 50% of the remaining events that can be averted. And this differs on the effectiveness of the primary series. And this is just to illustrate that it can be tricky when looking at relative estimates only, and also at relative estimates versus actual count numbers in a country. So the size is also sometimes difficult to interpret. So I'm just advancing this slide. Again, the different outcome measures came also up, and how crucial it is to have clear definitions of those. And for mortality, for example, it can be very difficult to distinguish between deaths due to COVID, deaths because of COVID. This was the same. Deaths due to COVID, or deaths with COVID, or deaths mediated by COVID. So all of these, and this might also change over the course of the pandemic. And then we also heard that for severe COVID-19 disease, hospitalization is not a proxy that can be used. So always the case definition needs to be also clearly adhered to, and in combination with among hospitalized or not. Then we have also seen this kind of meta-analysis here also from previous presentation, and here just to highlight that the different outcomes have also different vaccine effectiveness. So I think that's nothing new here, but just again to highlight that. Some of the summary points for the first part of the presentation before I then come into combining VE estimates is that observational studies have their merits in forming policies because these are the best that we have right now. And they're taking into account all of these different practical factors happening in the real world and the population. And despite these limitations that they have, but then with the guidelines that we have and careful considerations, the biases can be minimized, but one needs always be still cautious of their context. Yeah, for absolute and relative V, that was also mentioned. So the relative V's are useful for informing incremental effects, incremental benefit, but can be misleading otherwise. Although moving onward, it might be more and more challenging to get absolute vaccine estimates, especially as the remaining unvaccinated population might be very different now to those that being vaccinated. And also, as we have heard, there are still many questions that remain unanswered, especially on the booster, first booster, second booster across the different regions. So ongoing CVE studies will definitely be needed, and some way forward to make this sustainable to get these regular estimates. So for that part, it's just a few slides for the three different approaches that one can do or consider for combining the estimates across studies. One is meta-analysis, or also meta-regression, as we have heard an example from Anshu earlier today, or pooled analysis, which also came up and was presented yesterday for the Cairo region, or also systematic review and evidence synthesis, with just explaining these estimates without trying to quantitatively combining them. So these are busy slides. I just want to highlight some strengths, limitations, and requirements for all of these. So for the meta-analysis, so the obvious strength there is when looking at these plots, you can see the heterogeneity or differences across studies for the VE estimates. And then this does not provide a false sense of certainty because there's uncertainty, there's heterogeneity across studies. And here one can also do some weighting depending on sample size or maybe quality of a study. And then it still provides some overall estimates, but it's always in the context of all the different studies. And here the studies are only shown the author, but then one can also add information on the country to bring in more context. So one limitation there can be that it's prone to publication bias, depending on how many studies are done and which ones are published or not, but this can also be assessed. And there it also requires careful consideration of the outcome definition. So this is to be as similar as possible across the studies to be compared. And then it relies on the reported VE, so it does not have access to the raw data as pooled analysis would have done. And it also relies on the VEs reported, depending on their considerations, whether it's for a study specific period since time since vaccination dose. And then if someone uses a different threshold or criteria, one cannot account for it or correct this. And then there's a pooled analysis, and here I put a figure from the study from Cairo that was recently published in the Lancet study, so as an illustration. So their strength is that it can have increased statistical power to pool across multiple studies and combining their sample size for more robust VEs. And this is, and also single estimate is very trendy or nice for policymaking because it's easier to communicate. Although it can also be more challenging to communicate because of all the things that go into it, some of the assumptions that are not conveyed in a single estimate only. That's actually the first point in the limitations highlighted there. And then the guidelines also caution against pooling data if the populations differ by vaccine programs or policies, by the health system and care-seeking behavior, and overall infection risk across the studies and countries. And this also requires access to the raw data, so it's only possible when the data can actually be pooled, and this might not be possible for all the different studies being conducted also in the past, when not having this contact to the authors or PIs of the studies. Again, it also needs alignment of the inclusion and exclusion criteria, outcome, and there's a measure of heterogeneity that one can do, but Yeah, but if the studies are very different, then also this measure won't be helpful. So don't want to spend too much time on that slide. So there's also systematic review and evidence synthesis that can be useful. So we saw some living systematic reviews examples, and this one maintains the granularity at each of the VE estimates in their study context, which can be useful, but also takes more time to go into in each of the study, and might be difficult then to draw policy recommendation across all of these different studies settings and consider all the single factors. However, things are, since for COVID, everything is changing so much, it's also important to include all of these considerations. So I think there the tricky part is to find a balance. When is it too much? How much can we simplify without oversimplifying to make valid conclusions and recommendations? So for example, not every estimate needs to be done specific for a vaccine product, but then maybe by a vaccine platform might be granular enough, depending on the question and recommendation to do. I think this one is mostly, illustration again for studies. So there are some vaccines that have been studied across the 4 studies and some not, and then one could, some considerations are, again, the study design, sample size, also the time and variance when they have been conducted. And I think this needs further investigation to what extent these data can be used for a combined estimate. But I think I will leave that to the discussion, and then would also skipping that because it's just what I just said. With that, I would hand over to my colleague Thomas Cherian, who is online to talk about considerations for making policy decisions.
Thank you, Manuela, and good morning or good afternoon to everyone. Sorry for not being there in person. So it turned out that my 4 doses of COVID-19 vaccine were not effective in preventing me from getting an infection, so I couldn't travel. So can we go on to the next slide, please? So I'm really going to talk about what data are used to make policy recommendations and where does vaccine effectiveness data fit into that context. So I think first thing is, as has been pointed out, I think repeatedly, is that policy recommendations need to be time and context specific, especially during an evolving pandemic where things are continuously changing. And this is reflected in the WHO roadmap and WHO recommendations, which have been time limited and mainly applied to the prevalent epidemiological scenario. And based on this, I think now we have the 3rd update of the SAGE roadmap for prioritizing the use of COVID-19 vaccines. And these are periodically updated. And even the current recommendations may need to be revised as the pandemic evolves and we have additional data that becomes available over time. Next slide. So what are the factors that are considered when making a policy recommendation? One is the status of the pandemic and what are the existing rates of natural and vaccine-induced immunity in the population? What are the circulating variants and what is their immune escape potential? What are the disease control objectives? Is it severe disease and hospitalization and death versus trying to prevent infection or transmission? What are the priority target groups and what is the effectiveness of vaccine and the waning of protection in these target groups that you want to focus on? What are the program feasibility of delivering these vaccines and what are the competing priorities, or what would you not do if you did not, by giving COVID-19 vaccine or continuing COVID-19 vaccination, what are the other health priorities which probably would be not given to the same coverage that you would want to give? And what is the vaccine supply and availability? Next slide. So this is a quick snapshot of the most latest version of the roadmap and the recommendations. And you can see that this has now changed since the first roadmap. You can see now that for the primary series, that is persons who have not received a COVID vaccine, the recommendation is a single dose of the vaccine, except perhaps for the inactivated vaccines where it's still a 2-dose regime. And this is because of the recognition that almost everybody has been exposed, even those unvaccinated have had experienced a natural exposure and have some degree of protection. Next slide. And you can see that based on the, sorry, if you go back to the previous slide, and then based on the data of the waning of both the antibody levels as well as the waning of protection, there are recommendations on revaccination of persons who have received at least 1 dose of COVID-19 vaccine. And you can see that the terminology is also changed from booster doses to revaccination of people who have been previously vaccinated. And the intervals differ depending on the target age groups and the rate of decline in protection and the consequences of their not being they're being protected because of their susceptibility to more severe disease and death. Next slide. And this goes on to the lower priority groups. And again, here you can see that in healthy children and adolescents, 6 months to 17 years of age, there is an option for countries to not vaccinate them because if that is not a priority and it actually interferes with the delivery of other health services. Next slide. So how did or how could vaccine effectiveness data inform these policy recommendations? I think the data were useful in terms of the protection that was provided by the index virus vaccines and hybrid immunity against the different COVID-19 outcomes that are caused by the circulating virus variants. What was the rate of waning of protection in the different target groups and the relative effectiveness of the additional doses of vaccines? The incremental protection provided by the variant-adapted vaccines against the different outcomes, and this led into the recommendation that if available, an monovalent XBB vaccine was preferred over an index virus vaccine. And importantly, I think, and this happened even in the previous recommendation, is an estimate of the net benefits of vaccination compared to other health interventions. And this was done by a comparison of the numbers needed to vaccinate, that is the NNV, to avert 1 hospitalization of death due to COVID, as opposed to interventions that people might miss out on as a result of the continued focus on COVID-19 vaccination. And that is what led to the recommendations that vaccinate even the primary series vaccination with the primary series for children and adolescents is optional as compared to earlier recommendations where this was recommended. Next slide. And this brings us to my last slide, and which is a series of questions maybe that can help us with the discussion that will follow now. And first of all, because there has been a lot of discussion and maybe statements about doing pooled analysis, is to ask the question, what do, first of all, for us to understand and define clearly what we mean by pooled analysis. And I think Manuela did present that. Do we mean a systematic review when presenting the granular data? We did see from Anshu's presentation that she presented data from individual studies supported by some meta-regression to show certain trends. So this is more a descriptive analysis than a meta-analysis that provides a summary estimate of vaccine effectiveness. Each of these may have their benefits, but we need to be clear on how we use these different pooled analysis to help in policymaking. And this goes into the next question is what type of pooled analysis will assist in policymaking and what are the relative benefits and risks from using a more descriptive analysis versus having a more precise summary estimate from a meta-analysis. Just to give you an example, we know and I'm going to a different vaccine, which was the rotavirus vaccine. And we know that the rotavirus vaccine had vaccine efficacy of close to 90% in high-income countries. It was lower, around 70% in middle-income countries. And then when you came to low-income countries, it was 50% or lower. Now, if you do a pooled analysis and come up with a summary estimate, which is in between these three estimates, it's not useful to any of the three groups of countries because the difference was actually a real difference that the vaccine did perform poorly in low-income countries as compared to high-income countries. And so you need to, actually the pool analysis was maybe misleading in that effect by having a common estimate that across three different situations where the vaccine performed differently. So when we do a pool analysis, I think it's important for us to consider how do we pool the data, whether it is doing a systematic review and presenting the data or doing a summary estimate of the vaccine effectiveness. And should we do it by region, by vaccine, by target groups, by variant of concern, by the phase of the pandemic, as you know, especially in relation to, and we've heard this depletion of susceptibles and how it can affect the vaccine effectiveness estimate. So I think if we do proceed towards doing a pooled analysis, these are a series of questions of what exactly do we mean by a pooled analysis? How would this help in policy making? And if we do a pooled analysis, how should we pool the data and what precautions should we take so that we don't end up in a situation where the results are more confusing than helpful in making policies. And I think, next slide, I think that's the end of this thing. So we can go back to the previous slide and leave the questions up. And Lisa, I'll hand back to you if you would like to coordinate the discussion from there rather than me trying to do it from there.
Okay, thank you so much, Manuela and Thomas. Carsten, do you want to add to discussion, or we can open the floor for colleagues here to discuss this session?
No, please go ahead. I think we've been jointly working on these slides, so please go ahead.
Thank you so much. So I can see name stands up, so let's start with the discussion. So we will start with Dr. Nawal first.
Thank you so much for this review. My question, I think both of you are aware of what's available in the region. So if I want to do a study to pull all the to look at all the results, will systematic review work better or pooled analysis from what's available in the region? And what will be more useful? Thank you.
Thank you, Francisco.
Thank you. Thank you, Manuela and Thomas, for the presentation. I have a few questions, comments. The first question is about the exclusion of influenza positive from the controls for COVID-19 VE estimations. We at PAHO, we exclude this population because of the correlation with vaccination and potential underestimation of the VE. but we lost a lot of precision when we have concomitant influenza and COVID. So we'll miss a lot of information from there. I would like to ask Manuela because I know that some other studies are adjusting by this factor, so maybe she can provide something. This is first comment about the prior infection bias. We don't consider this prior infection information in our studies for two reasons. First, the information available is not reliable. We don't really have information about the previous exposure to the virus. And second, because we consider everyone already has been exposed or infected at some point in the past. So we don't include this factor in the analysis. And for the relative VE, I know it's a tricky question, which comparison group we should take, right? Since most of the population has been already vaccinated with at least primary series, we are considering including time since last primary dose in the relative as a comparison group. So we cannot compare a person who has received the primary series a few months ago with someone who received the primary series more than 12 months ago. We will consider this population as unvaccinated, where, so, and potentially provide this as an absolute VE estimation. And finally, for the pooling, the PAHO experience, we're using the surveillance protocol is the same approach for all countries participating in the network. So they have the same, they're using the same case definition, the same PCR testing procedures for all SARI patients admitted in the sentinel sites, hospitals. And so we assess the heterogeneity of these different sites to see if there is a big difference in terms of estimations. And if there is no big difference, we pull the data. Otherwise, we will present the data as a meta-analysis as Manuela presented. That's all. Thank you.
Thank you so much, Dr. Najafi.
Yes, thank you for both presentation. Very quick question about the pool analysis. What I have seen in the presentation, it says that the pool analysis is a descriptive analysis. I don't know, probably I understand it wrong in the wrong way, but for me, the pool analysis is the mixing the individual data and estimating the effect size, whatsoever is effect size, and then you can adjust for different confounding factors. So probably, I mean, in most scenarios, the pool analysis is more stronger than even meta-analysis because you have access to individual data. Please correct me if I am wrong, but this is what this is my understanding from the difference between pool analysis and meta-analysis. And again, the question that I asked yesterday, I was, talking with the different group, and I realized that, different teams did different things regarding the analysis of the vaccine effectiveness against mortality. So there are three methods for, analyzing the vaccine effectiveness against deaths, and probably their results are again different. So it's very important to decide which one to choose. Thank you.
Thank you, Kamal, Savario, and then Ms. Sirus.
Thank you very much, Manuel and Thomas. Actually, I had a big number of questions, but I just wanted to, I will concentrate only on two questions. As we have a parallel discussion with the PI here in some of the countries, we were discussing the negative vaccine effectiveness. And as we have mentioned yesterday, we shouldn't be shy to reflect negative vaccine effectiveness as long as you have explanation, and there are a number of big studies that have shown also negative vaccine effectiveness. But when we wanted to publish such a finding, and we need to have a very strong and concrete explanation, and looking to the most plausible explanation related to exhaustion of susceptible, how we would put strong evidence on exhaustion of susceptible, maybe if we can depend on the herd immunity, whether through infection or the high vaccination rate. But how we would explain that in the waning of immunity, which has been proven. So at a certain point of time, we don't have susceptible because they are depleted, but on the other side, they are starting to increase again. So how we would do this kind of a bit of complex relation. And the next question related to what we're looking forward at the regional level to have a pooled analysis versus meta-analysis. We understand very much the constraints of meta-analysis. However, for the pooled analysis, and here I'm echoing what Dr. Najafi has mentioned, I think there is a strength of having this pooled analysis, pulling together the individual data, have the bigger sample size and more statistically significant result possibly. But here, I just wanted to go to a specific entity in Manuela presentation saying that we should be very careful about heterogeneity of data from the different countries. We are expecting there are differences, of course, but this difference shouldn't be refraining us from pooling the data, knowing that we can pull them by a vaccine, for example. If we're taking one vaccine which have been used in many, many countries, what is the problem of having differences in the different studies, knowing that we're talking about a single vaccine? Talking about healthcare behavior, personal protective equipment usage, and all these kind of things. So I think this shouldn't be refraining us from having regional vaccine effectiveness. Otherwise, what will be the alternative to have a regional vaccine effectiveness figures? Thank you.
Quickly from my end, a couple of questions. One very technical and maybe with no a very possible response, which is about meta-analysis. Manuela, you said that one of the issues is publication bias. Is there any methodology, anything that can be done to counteract publication bias? Not sure about that. Then when we discuss about work at country level, the translation in policy for me is the most difficult step. I mean, okay, discussing about all the technicalities of this methodology, very, very important, but communicate the findings to the senior management of the Ministry of Health or a public health institute. For me, this is the most tricky, sensitive step. And so when, Manuela, you said listing clearly the limitation, listing how, in which way that you are not compromising the message you want to convey. And the second point for Thomas, you said factors to consider when making policy recommendations. And you listed rightly feasibility. I want to ask feasibility in terms of operationally, if you have, vaccines, cold chains, things like that, or also consider specific issues related to the community, like acceptance, like if it's the right time to proceed with specific policies, and things like that. Thank you.
Thank you, Sawario. Ms. Sirus, please.
Sorry, good afternoon, colleague, good mornings. Actually, thank you very much for very informative, presentations. I have one, it's not a question, but mainly to, to share my concern that, during this vaccine effectiveness, we are talking about the confidence interval, but we need also to think of the power of the study. Second type error is also very important. So in this stage, maybe we need to highlight power analysis, sensitivity analysis, so that we can, consider for all these vaccine effectiveness studies, this part is not missed in the, interpretation. So the more important part is to have, a guideline for the countries with the optimized sample size so that this power analysis and sensitivity analysis can be done to be sure that whether if we are rejecting that the effectiveness of vaccine, we are not in the wrong track for interpretation. Thank you. Over.
Thank you, Mr. Rania.
Thank you for the nice and the great presentations. My question is not specific to someone, but just thinking, and I want to share my thoughts with all of you. During the today's meeting, we have now we heard a lot of discussion about vaccine effectiveness, and it was very important to have this, that we know that the vaccine effectiveness is high. We have protection line and level is remarkable even after the first dose. But what about after that? We want to just to know how can we benefit from these studies and the huge number we have now regarding vaccine effectiveness in COVID with other vaccines like influenza, and copying the experience to other vaccines like influenza, seasonal influenza vaccination. And also we are facing now troubles in acceptance, demand, and consumption of COVID vaccine. So what are we going to do to deal with these kinds of problems we are facing, even we have vaccine effectiveness high? So what are going to do? Just I'm thinking loudly with you to have answers to these questions. Thank you
so much. Nawal, do you have a second question or comment, or this is from previous statement? Okay, so no other comments from colleagues online? So please, Manuela, over to you.
Well, let me start and then maybe Manuela can come in. This is Thomas.
Yes, Thomas, please go ahead.
Yeah, I think, I mean, just to get the terminology straight, I think we did use the word pooled analysis to say anything that we pool data together. So let's stick to the terms systematic review and meta-analysis just to make sure that we differentiate between the two. And I think one of the first questions that was asked was, should we do a meta-analysis or a systematic review? And I think it's not a case of either or. I think we should start by doing a systematic review, looking at the data, and then decide where a meta-analysis would be appropriate and useful in guiding decision-making. So it's not one or the other. I think you just need to first do a systematic review, look at the data, understand the factors that may be contributing to heterogeneity, and then deciding where would a meta-analysis be helpful and useful in guiding decisions. So I'm not advocating for, I think the systematic review is the starting point. The meta-analysis, you'd have to decide when it's useful and whether it is useful. So I think, Kamal, so I totally agree. There are strengths. So, and Manuela did lay out what are the strengths of doing a meta-analysis. So nobody is discounting the value of doing a meta-analysis. In fact, when you grade evidence for making policies, you do give a higher score when you have meta-analysis and where the efficacy or effectiveness estimates are all pointing in one direction. So there's no question that meta-analysis are helpful, but the question is, can it not be helpful? So for example, if the contexts are completely different, in the sense that if you are taking efficacy effectiveness estimate from early in the pandemic when the alpha variant was predominant, and the pool of susceptibles was high, so you didn't have depletion of susceptibles, your vaccine effectiveness will be high. And we have seen that in the data that were presented. So data that were presented from early in the pandemic when the alpha was circulating showed effectiveness estimates of 90%. And the estimates from studies done later on were much lower. And I think both Anshu and Danny referred to this as well. So should we pool those estimates and come up with an estimate that is in the middle of those two? That's a question that we need to ask ourselves, and how helpful is that going to be? I think, Kamal, you raised another question of how do we account for the depletion of susceptibles, and that's a good question. And maybe I'll even ask Danny or Anshu if they're still on this thing to maybe comment. We did talk internally about using data from the seroprevalence studies and the UNITY studies, and whether that in some way could inform or at least help us to understand the heterogeneity in the efficacy estimates that we are observing. I don't have the right answer now, but maybe this is something that we could consider or look at. Finally, as in terms of the feasibility, yeah, I think there are multiple issues that go into feasibility. And I think one of the important considerations that was taken, especially in the recommendation that said you don't need to vaccinate children, was led to the fact that, we know that immunization programs and health systems have been overstretched by COVID-19 vaccination. So if continued vaccination, COVID-19 vaccination detracts you from delivering other important health services, which will have a detrimental effect on the health of populations above and beyond the impact of COVID, then you need to take that feasibility and what are the opportunity costs of continuing vaccination in making policy recommendations at the national level. Of course, that is again contextual. It may vary between countries and maybe even within countries, and therefore you have to consider that carefully and take that into your decision-making process. I'll hand over to Manuela if she has any additional comments, and maybe Danny and Anshu want to weigh in.
Thank you, Thomas, and thank you all for the great questions and difficult questions. Just looking, so starting one with the easier one, or there was one question on the publication bias. So I'm just shifting back to another topic and then back to where we are. And then for the meta-analysis. So there's this funnel plot that one can do to see the size of a study and the precision to assess whether there might be publication bias or not. And this is then a technical approach to assess whether it might be an issue or not. And then otherwise it can also be reaching out to this gray literature. Maybe there's some reports. I think it's more of this manual work, reaching out to countries, to WHO, like people who might have initiated, funded, supported studies. So I think it's on that one. And the question from Francisco about influenza positive from control. So I see the point that if there's many who got the influenza or also vaccinated or infected, and then removing them reduces sample size and including precision. And then whether it would be an option to include them as a confounder or as a covariate in the model. I don't have a good answer for that one, so I would open up to people online, maybe Dr. Faikin or other people who might have an answer to that one, because I think it's an interesting point for that one.
Okay, so I think that we need to also clarify some of the questions, Dr. Arash, from our side. If you can go first, please.
I mean, if colleagues online, so
Carson,
you wanted?
see any hands.
I think Carson opened the camera. Carson, do you want to?
No,
have?
no.
Oh, okay.
Go ahead, please.
Many thanks. So, yeah, I mean, the session was really good. I mean, I enjoyed the presentations as well as the discussion, and it's very much also linked to the follow-up session. And I wish we had sort of our right colleagues with us here as well. So we have some colleagues are already online. So that's excellent. Because in a way, we also venture towards the use of the analysis for policy making, and what Thomas added on that front was also very pertinent. So we will be following some of this discussion later on. What Manuela also presented was really good, not only applicable to what we are doing and what we may do from now on, but it also included several methodological consideration issues about the capacity and the data, which are important. So in a way, I'm just want to spend maybe 1 minute on some terminology issues, because in a way we are working together, and so then just publicly we have all the same understanding. So Thomas, on the issue of the using systematic review, meta-analysis, and pooled analysis, or individual data meta-analysis, or whatever, I mean, different types that goes. I mean, I fully appreciate there are different people who use them differently, etc. In the WHO, we try to keep systematic review when we are talking of secondary review of published studies. So when the studies are not yet out, we don't use the term systematic review. So I know you may have been referring to the use of published studies, because there are also published studies under the discussion for the region as well. So I mean, let's agree on that. And then when it comes to the issue of the meta-analysis, I mean, I know, again, in the literature, some people refer to meta-analysis as a method of analysis. So the analytical aspects of it, some look at it as, again, as a sort of equivalent to systematic review, a systematic review that includes quantitative analysis. They call it meta-analysis. And again, for the pooled estimate. So in a way, so let's keep systematic review there. What we are talking about is individualized data, pooled data among the studies that are not yet published. And then also considering of including other studies from the region, and then putting them together with the virtue of access to individualized data. So it becomes an individualized data meta-analysis. So I mean, I guess we are all at the same place. I just wanted to just mention the terminology. And in that sense, I would also totally agree with what Thomas said about how to differentiate. I mean, how to use different approaches there. What I want to add, basically, I mean, there are questions on, I mean, there are two types of questions here. One is, I mean, two categories, and that slide, summary slide on what to do and how to focus is I mean, that's the focus of the work. So one type of the questions are, what happened next after, let's say, we have the results of the studies at the regional level? A series of questions are, what should be done now before we get there? So in a way, to finalize the analysis to get there. And I would differentiate those from each other. And so my main focus right now is on what to be done now. I mean, in terms of the analysis, different approaches, how to focus. I mean, those subgroup questions that Manuela and Thomas raised to all of us. I mean, those are the issues that are, I guess, more or less everybody probably would say, well, that's interesting also, that's interesting also, that's interesting. So I mean, in a way, probably we don't have a rough answer there. There is a tradition in systematic reviews, not in the context of vaccine effectiveness studies. I'm talking systematic reviews of, I mean, other contexts. When, for example, there are several studies coming in, and those studies are, let's say, I'm talking about another intervention. So here we don't know very well about prior infection. I mean, the distance, there are comorbidity questions that we are not aware or we are not sure. There are many, in other contexts, there are other issues. For example, you want to do a systematic review of effectiveness, whether, let's say, I'm simplifying, an educational study, educational intervention is effective or not. But then when you start to pull them together, you don't know what has been the intensity, you don't know what has been the quality of the person who conducted it, what has been the relationship between the provider of the service and recipient. There are so many things. But then what happens usually often is that you ignore all of those. You try to assess a rough effectiveness based on what you have, using the statistical approaches. And then you try to do certain sensitivity analysis to see whether if you pitch higher your questions, then whether it affects the point estimate or not. And if the point estimate remained robust, regardless of what you do, say, okay, I can say this intervention is effective if the positive result was effective. I would suggest, I mean, I'm not expert on vaccine effectiveness study analysis. I've done many systematic reviews, but this is not my area of focus. But my suggestion to the team would be that, I mean, let's try this sensitivity analysis as well during the process. I mean, so in a way, let's assume the data can be pooled unless proved otherwise. I mean, trying those pooled approaches and then seeing whether, I mean, sort of those additional values are coming out or not. This might be an added value of the study as well, in one sense, given that, I mean, we are bringing different virtues together. The other thing, I mean, for me, is a question, and I'm also, I mean, from Francois, did I say Francisco's, I mean, point about the study in PAHO. I mean, if I understood you correctly, you said, if there was a long distance time interval between the previous vaccination and the current vaccination, you considered it as an absolute effect. So that was the sort of assumption you. So, and I mean, here listening to Anshu, probably this is not a very safe assumption, because we know that, for example, the effect on the major outcome, which is mortality, may not be waning that quickly. So, I mean, that's an interesting thing. And I would say, I mean, similar approaches, again, in terms of as the sensitivity or not, would be important. And the concept of whether we can assume everybody has had prior or not, because I mean, again, I'm not the scientist in this area, you are. And to me, it's do we really know that everybody caught it, or there were parts of the society that even they didn't catch the disease or not? I mean, one for one reason or the other. So, I mean, that's also, then again, the question that comes in. So with those in mind, so my thing, it would be that sort of, so we like to have a pooled analysis. And I'm using the term with those caveats I mentioned earlier. So I mean, putting the data together, sort of trying to use the sort of, maybe using some meta-regression approaches to have all the data together, but with the meta-regression, we get subgroup analysis within one analysis, so it would allow sort of a better process there. And then testing certain assumption by sensitivity analysis using the wider data that we have. I mean, right now, in a way, this is also, I would say, given that the number of, I mean, I knew there are many vaccine effectiveness studies, but I hadn't been following the living review, and over 500 vaccine effectiveness studies, that's quite something. So in a way, we are a sort of a small fraction of that. So for us, is that also as a regional experience to going together, working together, trying to establish capacities, and as colleagues in HQ raised, making sure this capacity also, or trying to ensure this capacity will be used in future, then also salvaging these results as much as possible is important for us to show what are the potential added values, what are the potential things coming beyond the decision that the countries made. Lastly, what I want to raise, and I don't know if that would be also a question to Mehnaz and Kamal and Zahra and colleagues as well. So the issue of that, the certain unique sort of data that we have, for example, vaccines that have not been studied in other regions. Again, how do we stand there as well? So whether we want to also, how can we highlight those further as well as a sort of additional value that the regional study can provide.
Thank you so much, Dr. Arash. I just want to also add one point that what you mentioned, that's I'm just thinking that, Manuela, we have 4 studies that we discussed since yesterday, this Iran, Jordan, Egypt, and Pakistan. But the issue is, for example, for Iran, we have individual data, but we don't know what is the vaccine behind it. So we have the vaccine effectiveness result per person, per individual, but we don't know what was the vaccine that they used for that specific person. So, and no, we don't know. We don't have it. So it's not shared with us. So
I mean, you have the brand of a vaccine as well, but there are, for example, 5 or 6 type of vaccine that use less frequently, and we just added together as others. So most commonly type of vaccine used was Sinopharm and AstraZeneca and Sputnik. So we have all the information about these vaccine, but very, very few number of the people use
Iranian and other vaccines.
Yeah. We just pull. But we have all the brand of vaccine.
Okay, so thank you for this clarification. So the question now is, so we have now for studies, I'm just talking about regional studies. So because, there was a discussion yesterday that if we can also pull the results of other studies, for example, from Morocco, Tunisia, Qatar, Emirates, and also we had from Saudi Arabia, if we can merge also pull this data together to have a kind of regional results, but not just including these 4 countries, having more countries. And it was also another discussion that if we can merge the results of regional study with other regions, for example, the results from PAHO or others. So this was also some of the discussions that we had yesterday, but just focusing on regional study, I'm just thinking that now we have these 4 studies, 2 cohort, 2 test negative design. And also, I mean, there are somehow in same duration of time, but different design, different methods. So the question now is, because we, as you mentioned, Dr. Arash, and also we had discussion with Kamal, that we want to have the kind of pooled analysis. So our question is, whether we can do this, Manuela, or for example, you need to think a bit more, I mean, with your team about the limitations, restrictions, or the way that we can do this pool analysis, because this is what we want to do. And this is separate from having that regional results with other countries in the region, or for example, with other regions. So I want to also have a kind of very clear answer to our own regional study as well. Okay, so Kamal, you want to? No, this is the same things that Dr. Arash said. Okay. Okay. Kamal, you go first.
Yeah, just thank you very much, Dr. Arash, actually, for always referring back to the textbook definition of systematic review and other terms. This is very much appreciated. Also want to thank you to put the roadmap for the further step in doing analysis. We know that systematic review is always implied to publish studies. But I don't think that there will be any harm to do a systematic review to see if any heterogeneity internally, as you are an internal team, to do systematic review or the 4 studies which we have now to test if there is heterogeneity. And I think also there will be no harm to start doing pooled analysis and see what will be the results. Is it going to be very odd, or is going to be concomitant with the countries one? So here we need to understand if it is good, there is no problem to publish it. And then when it comes to limitation and explanation, we can do that. So there is no problem in doing this pooled analysis, having a bigger number of data while considering the heterogeneity coming from the different data. On your last question related to why we don't do a specific small type of analysis related to some vaccine which had not been used, I think this also only applied to Iran, having been used some Irani manufactured vaccine which have not been used by other countries, and then we can do this analysis. However, Dr. Najafi has mentioned that there are very small number of those people, a very small proportion of people who have been using this vaccine. So maybe it turned out not to be very much significant, but I think this is a good idea also. And when it comes to a regional vaccine effectiveness, actually I was discussing with Maria yesterday that we need to do 2 types of regional, one implying the 4. And here comes the question of Mernaz, are we going to pull the 4 together or 2 by 2? And in the same time, we do a bigger pooled analysis for other data from other countries who will be kindly sharing us their individual data. So have to have a much bigger regional vaccine effectiveness studies as well. Thank you.
Thank you, Daniel.
Okay. Hello. Very interesting discussion that you're having there about what to do with the data. And I had a few reflections on that. I think what we've heard from Manuela and Thomas is that there's really 3 approaches to trying to look at the regional VE data together. The first is a systematic review, where you just essentially collect everything that's there, put it together, and see what the whole of the results look like, without combining anything. And certainly I would agree with Thomas, that's really the first step, is to understand what you have, all the characteristics of the studies, and lay them out in a table format or something where you could just see it all together. I think from there, there's two other options that I'm not quite sure where you're leaning on it. I mean, one is to take that and do a meta-analysis where you sort of take those studies and you use the meta-analysis techniques to come up with a summary estimate. The other is actually pooling the data, where you take the case-based data and you put it all together, like they did in the Revelac network, which is, I think, a different approach. And I guess when I think about why would you do a meta-analysis? Why would you want to look at all the data together and get a summary estimate for the region? Well, the one reason would be if you have discrepant results. So if you're seeing different VE results and you're not clear what the truth is, and you're having some smaller studies and you want to put it together and get a summary estimate. The second would be if you have few studies for a single vaccine. And I agree with the point that was brought up that some vaccines like Sinopharm are used more in the EMRO region than anywhere else. So that could be a useful addition, particularly if most of the studies are sort of small, they have small ends, and you want to gain some precision. And then I guess the third reason would be if you think that maybe your VE results in the region would be different than the global results for some reason. And Thomas brought up the example of rotavirus vaccine to make the point that that there you really did expect different results from different regions, and that was because rotavirus is an oral vaccine, and there's different enteropathology in different parts of the world, and that's why the vaccines behave differently. I don't think we've seen that with COVID vaccines. We haven't really seen regional differences in vaccine performance because of the way these vaccines work. I think the heterogeneity in the effectiveness is much more based on the vaccine or the population characteristics. Whether it's immunocompromised people or even the elderly compared to younger adults kind of had the same results for most VE studies. So there's just much more similarity in the results that we've been seeing. So from a regional perspective, I don't think necessarily you'd be expecting the vaccine effectiveness to be different in the EMRO region than elsewhere. I guess a few cautionary notes in thinking of either doing a meta-analysis or pooling. One is this issue of variance. I mean, we really see the effectiveness differs by variant, and was much higher for the earlier variants. For Alpha, for sure. For Delta, we start to see some drop off, but still high VE against severe disease. Omicron was just a different ball game in the sense that the VE was so much lower against infection. So I'd really caution against trying to combine a VE study for Alpha with one for Omicron, because there you're basically averaging two things that are quite different. The second would be maybe caution in combining different vaccines together in a meta-analysis. And the last would be in populations. And I think this is an issue for you. You have two studies that are cohort studies in healthcare workers and two studies that are test negative designs. We know healthcare workers, because of their profession, tend to get exposed a lot. So they have a higher risk of exposure, multiple exposures, and getting infection. So that would be a different population, say, than a general population in combining it. So I guess what I'm saying is that I would start with the systematic review, see what you have, see what's like and whether you can do some sort of meta-analysis or potentially pooling if the data structures are similar, but with like and like, not trying to put everything together, different variants, different populations, because I think what you'll get is something in the middle, an average that might not really give you the answer you want for certain populations. So those are just some of my reflections on listening to your discussion.
Thank you, Daniel. Thank you. It was very helpful. So we have now questions from Ahmed, Dr. Zia, and then Dr. Arash.
Hello, everyone. Thank you very much for your presentations and comments. And they really were helpful and really rich. So I have a few comments, and maybe we can get one question out of this. So for regional perspective, I think I've done a few meta-analysis, systematic review and meta-analysis. And for the regional perspective, I think we have really few studies to be able to pull the results. So we have 2 case control studies from Jordan and Iran and other 2 cohort studies. So I think we can pull case control and cohort studies in the same meta-analysis. So what I recommend to conduct patient-level analysis, maybe panel data. Maybe we can collect all data just like Daniel said. Just collect the data in one big data set and do panel analysis, maybe, and have the country level, the hospitals as random effect models. This is maybe helpful. In addition, the second one, I think, yes, there's, I recommend, maybe, I think there's a need for really well-developed systematic and meta-analysis for the vaccine effectiveness and conduct really a large meta-analysis, including all published and unpublished studies. And really conduct really subgroup analysis, meta-regression. However, we need really, I think there's a large number of studies that we can conduct meta-regression for different subgroup analysis, maybe by strain, by vaccine, age group. I've seen many forest plot for meta-analysis, but most of them really merging or combining many unrelated categories with each other. And finally, for the heterogeneity, I think heterogeneity cannot be excluded. Homogeneity is expected and cannot be rolled out. What I'm thinking is maybe we can adjust the weight for each study, included the study, by the sample size, maybe by the economic status of each country. So we can really adjust the weight instead of doing any other subgroup analysis. I also because of heterogeneity, we don't really, for this vaccine effectiveness, we want really to have how much vaccine is effective. Does it like 10% is effective, like 90%? I mean, 90% is better than 10, but is there a cutoff points that we need to consider? This vaccine is effective and cost effective, and whatever. What is the cutoff points that we need to really focus on? Because of lack of heterogeneity, homogeneity, I think we need to categorize the vaccine effectiveness to subgroups, maybe low, moderate, and high for the included study. This may reduce the heterogeneity, maybe the effect of heterogeneity on the overall estimates, the overall estimate. And, you know, like meta-analysis, you can conduct random and fixed effect meta-analysis. We should do random effect for everything, difference between the countries. So yes, my question is there any cutoff points for VE to be considered effective and cost effective? Is there any study that really studied the cost effectiveness of vaccine? Thank you very much.
Thank you, Professor Zia.
So just be very precise. So for publication by, so just say this funnel plot, which you can see visually, but then there's the eager test, Q test, we can usually quantify the publication by. Very sophisticated method is available there. For this meta-analysis, I believe that is Arsh mentioned that I think you can also do it for the published data. So for the published data, there are 2 types you can use. You can just take the results and its variability and confounding factor. But if you request the studies authors who have the original data, and they gave you the original data and the variability and the confounding factor, then you can just pool in. And if it is possible, you cannot force it, but it's possible you can do a published meta-analysis of the pooled analysis. For the vaccine comparison, I think this is a sensitive topic. So if you want to do this comparison, because you were told that we should not do it, in Pakistan, we have used all type of vaccine. So if you want to do it, then we have the data you can provide. But there is some sensitivity behind this, why government gave some vaccine to some and to others. So you are aware of that, but this is, if you want to do it, then we have the data.
So, Fatima, please.
Thank you. I was thinking about what should be done at this point. Maybe the discussion is about how to do the meta-analysis, systematic review, or pooling data. But at the end of the day, we will have a final result, maybe somehow in between high or low, but will the final result fit the country-specific level at this point of the COVID-19 epidemiological situation? Because there is studies done early in the pandemic and others late in the pandemic. And I'm not talking about the heterogeneity of them. I'm talking about the need of VE in each time. So maybe additional action should be done as the burden of disease now, the cost analysis, effectiveness of the vaccine itself at this point, and then combine to the regional result for the whatever the methodology will be used, and then have the final decision for policy making. Thank you.
Thank you. So Carsten, I think that there is no more hands. So Carsten, when you're sharing your comments, please, if you have also answers to the questions raised by Ahmed and Fatima, please also answer those as well. Thank you. Over to you.
Right. Thank you very much indeed. And this is a very important discussion in looking at it. It already goes into the next step. So what next? What to do now with all the data available? And what I could suggest is that we have a further discussion as our kind of support team to say, right, now that we've heard all of the other data beyond the 4 studies that we have been working on, let us do what you had suggested and start out an overview, the table that you had suggested as a systematic review or start of a systematic review of all the data, of all the studies that are available, the published and potentially those that you know of that would be available in the region, and put this together, as Manuela had suggested, with then the next steps as being the meta-analysis and the outline of how that would look like, or the potential for the pooled analysis, looking at the issues that would allow this to go forward or potentially not to go forward. So I think that would be a next step that we would suggest in discussions with you to put together, and then see what the conclusion could be, what the next steps and the best way of combining these data are. I hear very loud and clear that you want to have such a pooling of the data for the region. We've heard the downs and the pros for all of this, and I think it would be worthwhile putting all this together very concisely, and then have this further discussion. As for the other discussions on cost effectiveness and other issues, I think this is going beyond what the data would allow us here. It's about the next steps in preparation of the next pandemic. And I think that is something that would have to be discussed again in a different format. I don't know whether Thomas, you want to add a few words to this as well.
No, thanks. Just to agree with you, I think we should start with the systematic review. I think we should look at the data, what it's telling us, try to understand what's driving the heterogeneity, where it makes sense to pool the data and do a meta-analysis. I think keeping in mind what is the value added of doing a pooled analysis. I think where there is value added of the pooled analysis, we do the pooled analysis, taking care, as Danny said, to pool only like with like and not otherwise pool data. So I think we already heard about a way forward of maybe pulling the data from the T&D studies and then separately pulling the data from the cohort studies to keep the health workers separate from the general population, giving their differences in risk of exposure. So I think there are areas where the pooling may be useful, helpful, and give us more precise estimates, and other places where the pooling may not be helpful, and there we avoid trying to do a pooled analysis, which would not really help us in any way. Thank you.
Thank you so much. So Manuela, please just in 2 minutes, less than 2 minutes.
Yes, I might need just 30 seconds. Just a comment to what Carsten and Thomas said also on the pooling. So I think this is for the epidemiological meaningfulness also. And I think technically what we can also try is then for the T&D and cohort. I agree that these need to be separate. There's different populations, but just maybe to get an estimate on this heterogeneity estimate, this covering Q and I, because if the heterogeneity is 90%, there's no point in discussing whether to do pooled or not, just from a technical data point. So I think in parallel, while exploring systematic review and where it makes sense, also if it's from the data point feasible to do.
That makes sense. So no, we don't have any more comments from colleagues here and also colleagues online. Dr. Arash, for your final words for this session, just please in 2 minutes maximum. Thank you. So very small one because we are quite behind schedule, please.
I just wanted to categorize the types of vaccine into 3 types. Either the oldest one is the inactivated, then the vector-borne, then the newest one, which is the mRNA vaccines. And we can do a pooled analysis regarding these types, 3 types. It will be fine to know this on that basis. Either vector-borne, inactivated, or mRNA vaccine.
Not based on the brands, based on the type. So there are different options available. So we think that we need to go for each of them and see their strengths, the weakness, and kind of limitation to see which one is the best one, for example, for the region to be done. So I'm really in a hurry. In 2 minutes, please.
Oh, okay. No, I mean so we have a meeting on Thursday. So Mehnaz just informed me to discuss the next step on analysis. I would request, also other colleagues who are in the session. So, if you have ideas on what needs to be done further, and if you have interest to be engaged, also raise with Mehnaz so that it becomes part of our planning for the next steps. Obviously, the PIs of all the 4 studies will be involved in the process anyhow. So the only thing I would just say as maybe sort of to end this session, as Mehnaz has very clearly ordered, is that I know technical discussion can continue forever. So there are some, we have some benefits of post hoc view of the situation. So things we are aware now that we were not aware when the studies were designed. Things we are aware of that we were not aware when the studies finished. And so now, in a way, I don't want to confuse those with each other. So in a way, there are plans. So we should, stick with the plans and then see whether the plans, which one of them makes sense or not, as we always do for analysis of any data, and continue with that, and then see how it adds value. Because for me, from a standpoint of WHO, is that also important. This large scale support, we've never done that in this region for such studies. I want to see whether we should do it in future or not. So, and I can't leave the questions unanswered. And so saying that, okay, because now we know there is the answer of this question now, So I want to know whether this answer was valuable also a year ago or not. So in a way, so that's the concept that we are working in, and that I think we should do. But then obviously it should be done according to all the criteria. And the concerns that colleagues raised, I would add to those as well. There are more concerns. So we are not unaware of the concerns. The main issue is that how to handle those. Yeah, thanks.
Thank you so much. Thank you, colleagues, for this interactive and really great and interesting session and discussions. Good afternoon, colleagues, and also good afternoon, colleagues online. I want to welcome colleagues who joined us now in the session that we will have on how we can use the results of vaccine effectiveness studies to inform policymaking. So welcome, colleagues. We have esteemed colleagues from RITAC and NITAC groups in EMRO. I would like first to ask you to introduce yourself, please. Then we can start the session with our first kind of technical presentation from Dr. Kamal Fahmy, and then we will go to the discussion. So before starting the introduction, I just want to explain a bit about the reason and the aim of this meeting. As you are aware, colleagues, we did a regional COVID-19 vaccine effectiveness study to develop and to produce some regional and national, I can say local data on vaccine effectiveness from COVID-19 vaccines during the COVID pandemic. So now we have this meeting today. We have this meeting since yesterday with countries who participated in this study. We have Iran, Egypt, Pakistan, and Jordan. And also we have colleagues from other institutions and ministries of health from the region and also other regions. We have colleagues from PAHO and also colleagues from Geneva that also they did other kind of studies regarding vaccine effectiveness studies. So we are here to discuss and to share our knowledge and experience with each other. At the same time, we want to see how this data and how these results can be used to inform policymaking processes, mainly in our region. So this is the aim of this session.
Thank you very much, Marnaz. Thank you very much, Dr. Azzuddin, and all RITAC colleagues who are joining this very important session today. And I think this presentation will just set the stage for more discussion and getting input from the participant in this meeting to know more about how we can guide the immunization policy based on a specific entity, which is vaccine effectiveness. Knowing that to guide immunization policy, a lot of evidence are there, but here today we're gonna discuss only vaccine effectiveness. And you might remember these golden days when we see these mega vaccination centers where hundreds and thousands of people were gone to this place to get their vaccine, as compared to the latest SAGE recommendation, which has been released only last month to relax the situation and the decision about vaccination. Just to show how this is dynamic and has been changing from different levels throughout these last 2.5 years. In this presentation, we're gonna go through some entities related to vaccine effectiveness from the immunization perspective. We will go through programmatic criteria for vaccine effectiveness. We're gonna get into some details related to the coordination with NITAG as far as vaccine effectiveness studies are concerned. And we will going to the recommendation to guide the immunization policy with a few bullets of summary at that. I'm starting this presentation to see how WHO is looking at the vaccine effectiveness as a foundation of immunization policy. It is considered as a pillar for immunization policy. And WHO is advising on the overall global policies and strategy, ranging from vaccine and technology research, development, and delivery of immunization, and even its linkage to other health intervention. That's why we have been discussing integration yesterday, how we're gonna do integration of the immunization within the broader context of the primary health care. Going to another side of the coin, looking at what CDC is saying, CDC is saying that immunization policy is a balancing act between vaccine effectiveness, safety, cost of vaccination, as well as the burden of disease. So in a nutshell, the vaccine effectiveness and immunization policy are essentials for protecting public health from vaccine-preventable diseases. And by monitoring this vaccine effectiveness, and here when we're talking about vaccine effectiveness, it is a dynamic. It is not only one-time vaccine effectiveness study, but it is a dynamic process to update the immunization policy as needed. So we can help to ensure that everyone in the community has the best possible protection against VPDs or vaccine-preventable diseases. When we wanted to measure the performance of any vaccine, there are different levels with different measures. So we can test the immunogenicity of any vaccine at individual level, and this is actually the capacity of a specific antigen or a vaccine to produce antibodies. When we're going to the vaccine efficacy, it is a reduction of risk of infection or disease among vaccinated individuals resulting from vaccination in a careful, controlled circumstances. So more theoretically than practically. And this comes from randomized clinical trials. And we have seen in the presentation of Daniel this morning that the randomized clinical trial are always running in the beginning. And then observational study, from which vaccine effectiveness study is one of them, is running after. Why it is after them? Because it is reflecting reality. So the first one is reflecting the theory. The second one is reflecting the practice. So the vaccine effectiveness is reducing the risk of infection or a disease among vaccinated people attributed to vaccination, not attributed to anything else, attributed to vaccination in a real world, estimated from observational, non-randomized studies. There is a larger and broader context of vaccine performance, which is the vaccine impact, and this is population-based. This reduction in the incidence of an infection or a disease in a whole community or a population, and this detect the vaccine coverage, which is a direct effect in vaccinated and indirect effect of the herd protection, and we have been discussing this when we were talking about the herd immunity. And then also, it can also pertain to other measures beside disease. So we are talking here about the effect and the impact on a broader health system. COVID-19 vaccine is introduced, and we need to evaluate. So we can do the evaluation of real-world performance of vaccine in general. Not only vaccination, but vaccine as well. That's why we might be considering the cold chain of the vaccination, the general population, and different circulating virus variants. Also, we need to address the gap in evidence of vaccine efficacy from clinical trials. So vaccine efficacy at a clinical trial experience base versus the vaccine effectiveness in the real world on an individual performance base. We need to know the outcome of the interest, and the outcome of interest could be infection, could be transmission, could be severe form of disease, could be ICU admission, could be death. Also, a subpopulation at risk, when we're talking about, when we look at the latest SAGE recommendation, there are categorization of specific subgroup of population. So we might do vaccine effectiveness for specific subgroups, whether the elderly population, whether people living with HIV, whether healthcare, whatever, healthcare workers, or any other group. We need to know the duration of protection from vaccine, and we know that now that there is a waning of immunity. That's why there is a recommendation about booster doses. We need to know the effect of new variant or antigenic drift, and then that's why vaccine effectiveness have been also divided into based on the circulating variant, whether Delta, whether Omicron, whether even initial variant or the Alpha or Beta. Effectiveness of vaccine, co-administers with routine vaccines. Nowadays, and since the last 6 months or maybe more, we are calling for integration of COVID-19 vaccine within the routine immunization. So it should be a part of the routine immunization that it is given by the EPI program in the countries. Also, we can be providing input in models to estimate the impact of vaccine at a broader level, and we provide post-authorization confirmation of effectiveness for conditionally approved products. We know that the initial vaccine has only got the EUL, emergency use listing, but not pre-qualified totally by WHO. So we will be passing now to the pre-qualification of these based on the vaccine effectiveness results. These are some suggested criteria to undertake the vaccine effectiveness from the immunization perspective. So we should have a clear public health rationale. We should have a very well experienced epidemiological team. That's why we were calling for the integration between the academia and the Ministry of Health in order to have a very well established epidemiological team with a dedicated staff, with a specific identified site for enrollment of cases, with availability of reliable diagnostic tests in the study population. And in our case, we're talking about RT-PCR, the ability to ascertain a specific vaccination status and vaccination coverage. We cannot do a vaccine effectiveness study while we have a vaccination coverage of 10%. We will see that we need to start at least with 30% vaccination coverage in order to be able to estimate the vaccine effectiveness. We are talking about the data collection and management, as we have seen in our regional network here in the country's study, how much data management is a very important piece of undertaking this analysis. With ability to enroll enough participation with a big sample size. We will be also later on doing the data dissemination plan and place, which are doing in this workshop, as well as we have a functional ethical review. And we have seen that some countries, they don't have an ethical review committee in their countries, and they are depending on the regional one. And here comes the collaboration between the regional country level in order to have this ethical review committee to review the protocol and approve the study. This is again, it shows us what are the elements to be considered while conducting a successful vaccine effectiveness studies. And here we're talking about a valid vaccine effectiveness studies. As we have heard from our colleagues, there are a big number of studies that have been conducted with countries, but not being able to be validated because of a small sample size or wrong study design or whatever. These are the existing platforms that we can be using in order to undertake our vaccine effectiveness studies, either an established surveillance system, and we have been talking about different surveillance systems like SARI or ILI or other syndromic disease surveillance in Sentinel Site Hospital, and we have been discussing this morning in an elaborate discussion on what are the platforms that have been used or could be used to establish the vaccine effectiveness studies. Also, the health worker surveillance, which is one of the protocol adopted by WHO to undertake the vaccine effectiveness studies. Also, we have different administrative data that are available at different countries that could also be used to run the vaccine effectiveness studies. And also we can get benefit of a well-defined outbreak of a disease that could be used for other vaccine. It has not been used for the COVID-19 vaccine, but it has been used in other circumstances for other vaccine to test its effectiveness within a well-defined outbreak. These are the design that we have been discussing since morning, the different design, the test negative design case control or the cohort study. But we shouldn't forget another quick screening method, as we can see in this normogram on the right-hand side. This could be used to check quickly the vaccine effectiveness in the country if we have what is called the PCV and PPV. The PCV is a proportion of cases vaccinated. So we have a number of cases and we get the proportion of vaccination, and then among those cases, and then the proportion of vaccination in a population, which should be at least exceeding 30%. And looking to this normogram, we can usually track quickly how could be the vaccine effectiveness in this country. This is called the rapid screening method that could also be used if the facility to do a TND SARI case control or healthcare worker cohort is not available at the country. When we start talking about guidance to immunization policy, vaccine effectiveness studies are done where needed. Where needed means that not every country need to conduct a vaccine effectiveness studies. So we need to have a sufficient vaccination coverage in the country, in addition, of course, to all the capacity that should be there in order to undertake a vaccine effectiveness study. We should reach a specific vaccination coverage. And why we are saying this? Because in our vaccine enrollment in our region, there was a reluctance in some countries to do vaccination. So only they got the high vaccination coverage very late. However, some other country which has started from day one vaccine introduction, they have attained a high vaccination coverage going with the recommendation of WHO in a very short time. So we need to know this vaccination coverage. But what about if a country, they didn't get the needed vaccination coverage? Can they do a vaccine effectiveness? That they can. Yeah, they can have it in a specific group if this group has attained a high vaccination coverage. So it will not be a population-based, but a specific group-based. Also, specific initiative to reach and document the high coverage. So we should be relying on a very strong platform detecting the vaccination coverage. We need a large population size, and we need to consider the vaccine product. We have been discussing with our colleagues that in many countries that they have 6, 7, 8 vaccines. Whenever vaccine come in the market, they use it. So how are we going to do vaccine effectiveness study with this very big number of vaccine, taking in consideration of the large sample size needed? So we should be also considering this variety of vaccine which was available in the market at a certain point. How are we going to test the outcome to consider for policy guidance? So when we're talking to policy decision maker, we need to tell them that this vaccine is preventing an outcome. Maybe the immunization policy will be interested in having averted deaths, or averted hospitalization, or averted infection, or averted transmission. So we need to make sure that we have a basic concern about symptomatic disease and severe form of disease. And we have realized since morning that the definition of severe disease might be different from one country to another. But we should be adopting the severe disease definition in order to be clear when we convey our message to the immunization policy decision maker that this vaccine is preventing such an outcome. Also, some advanced cases, some advanced situation also could be addressed when we are doing vaccine effectiveness studies, which are a bit more difficult in the analysis. Why? Because what we have been discussing earlier before this presentation on a confounding factors. So there are a lot of confounding factors playing in mortality. So that is an outcome, but it is difficult to prove unless we have a very sophisticated, detailed, strong analysis, or the infection, detecting the infection, or more difficulty detecting the transmission. But if we concentrate on the basic outcome about the symptomatic disease or to the severe form of disease, including death, this would be strong enough to advocate and to convince the decision maker about our vaccine effectiveness studies. We need to consider specific studies for according to type of vaccine. But in order to take in consideration the type of vaccine, we need to make sure that there is a large proportion of population that have been vaccinated with this vaccine. And we have this discussion earlier this morning about a country who is utilizing a number of vaccine. And because of the small proportion of population using specific vaccine, all of 2, 3, 4 vaccine have been put together as others. So we need to make sure that we have a large sample size representing each vaccine. Also, following the national deployment of vaccine, the NDVP framework that have been utilized with a specific plan for introduction of the vaccine in every country, we need to have the proportion of the population coverage. What are the prioritized group based on SAGE recommendation and reconfirmed by vaccine effectiveness, our target approach, and a specific special population. And needless to say that in our region, 50% of the countries are in emergency situation, and maybe 8 countries are suffering from mobile population, if not from internal displaced population, IDP. And there is a specific publication of WHO that it is considering this special population vaccination coverage. Here comes what have been discussed earlier about this kind of collaboration, coordination, understanding, working together of 2 different teams. One team are the research team doing the vaccine effectiveness, and one team are the policy decision maker or immunization policy. So we need to work on, when we are seeing the green part, this is the side of the EPI program, the higher level, the immunization policy decision maker. They need to understand why. We need to say why we should be introducing this vaccine, depending on the results that are depicted from our vaccine effectiveness study. And then, so what? What will be the implication of the vaccine? Number 2, when it comes to the violet color or the purple color, it is coming from the academia. What will be the role of the academia which is to do the suitable study addressing the research question, and then to answer the question of how the capacity building to ensure the highest research quality for a reliable estimate. And earlier this morning came a question: who should be informing the decision maker in the country? And the response I heard that you. You means the group, the team that has conducted the VE studies. After you do your study, your analysis, you come out with the result, you should be able to go to present this to the immunization policymaker. And this is very easy in a country where the Ministry of Health is working closely with the academia, that it is very overt in a number of countries in our region. But unfortunately, in other countries, this kind of lacking cooperation is hindering the delivery of the message to the immunization policy decision maker. Here, I'm borrowing this last couple of slides from my colleague, Dr. Gerald, who is with us, who is the focal person of the NITAG. And he has been contributing to another workshop related to evidence to recommendation. What are the steps that should be fulfilled, should be followed to reach the recommendation? And here we have 4 different steps. Number 1, the question, that it should be having an answer at the end, or having a recommendation at the end, focusing on the NITAG or the National Immunization Technical Advisory Group that should be having as an answer to take a decision. Number 2, what are the criteria that I have been using from my side in order to present it, in order to prioritize the need of the vaccine, if it is critical, if it is important, if it is less important. And this seems to be simple. Is this a critical decision or important decision? Who can answer, is this a critical or important? Depending on what? Depending on the situation that will happen if we don't introduce this vaccine, or if the vaccine is not effective. This what will be the impact on the population. If it is hospitalization cost, death cost, whatever it is. So we need to be very clear when we are setting the criteria. And then what is the evidence? Is the evidence is good enough to support this criteria in order to answer the question? And here we are needing to sensitize this evidence in order to reach the step of evidence to a recommendation. And we should be preparing our document. We should be very well prepared when we go to the immunization policy decision maker to get their answer. And then the recommendation is to discuss the draft on a recommendation and then voting on recommendation. One piece of practical point I need to discuss here. We have been in our career, all of us experience all the work that has been done and that has been put before the decision maker, but we don't have any guarantee that our decision will be heard or our decision will be taken in consideration. Why? Because the policymaker, maybe they have other criteria that they would consider. And we are facing this for every new vaccine introduction in the country. We are fighting to get some vaccine introduced in the country, but at the end of the day, this was not the priority for this country. So we do our piece of work, we present our data in a reliable and plausible way, and then we leave the recommendation and decision in the hand of the decision maker. And this, when it comes to the step 2 that we have seen 4 steps. And when it comes to step 2, we have certain domain, we have 7 domain to be considered here. And here we're gonna focus on domain number 2, which is the benefit or harm. So there was discussion yesterday, and Dr. Azzeddin has been very wisely advising us when we are doing vaccine effectiveness study, do we need to discuss, for example, the adverse effect following immunization? And the response was yes. We need to be honest, frank, and open and say that this vaccine is effective in protecting the population with this proportion to avert this number of deaths or ICU admission. But on the other side, we have a very minimal risk of having this adverse effect. And here, what is mentioned that the harm versus the benefit. So our desirable anticipated effect is big or it is small? Are the balance between the benefit or harm, is it okay to be considered? And here the decision maker will put the balance between both and decide at the end of the day. In this domain, we have been asking this question. And when it comes to some element related to the vaccine, we are considering the characteristic, the safety, the efficacy, and some indirect effect, or including the EFI. But when it comes to the efficacy and effectiveness, and we have been saying that efficacy is based on the randomized clinical trial before introduction, while effectiveness, it happened after introduction and reaching also a high level of vaccination coverage. So we are talking about the type of protection that it is afforded through the vaccine effectiveness studies. We need to determine the critical determinant of the immune response mechanism, how much this protection was lost in the community after having this vaccination, and we need to understand if it is interfering regarding the immunity with other vaccines. This is a very important thing to be considered also while putting the decision at the end of the day. Vaccine effectiveness is one of the measures. It is not the only measure. It is one of the measures to understand how well vaccine is working. And it is a key piece of a whole puzzle that should be put as an evidence to make a decision. COVID-19 illustrated and showed us a lot of lessons learned during the COVID pandemic about the importance of differentiation of outcomes of vaccine effectiveness studies. And then while we are working with countries to introduce new vaccines, we are taking also in consideration this variability in the outcomes. The effectiveness is examined with a range of methodology, with a quick screening method or the different design, which are TND-SAR, case control, or a prospective cohort healthcare worker. Working on vaccine effectiveness has many programmatic aspects and some operational research aspects that should be respected. The National Immunization Technical Advisory Group are the most important body in the country to be engaged in establishing the need of vaccine effectiveness studies and making use of the results. And here I would recommend from any research team in the country, when you are starting a vaccine effectiveness, you should be including the NITAG from day one, which I don't think that was the case of the studies that have been done in our countries. So we should be including them from the beginning, so as when we present the result, they are aware about all steps which have been taken. Vaccine effectiveness is a cornerstone in guiding immunization policy, whether to introduce a vaccine, to continue the vaccine, to change the vaccine, to look at the doses of the vaccine, anything related to the vaccine. So it is a dynamic, continuous process working together between the research team as well as the expanded program of immunization team and the NITAG. And finally, I would like to emphasize the recent role of the Regional Immunization Technical Advisory Group that we have. We have a very well prestigious, prominent 10 focal person led by Dr. Azzeddin as the chairman of this NITAG to guide all the countries. And we have started this month to work closely in collaboration with NITAG in every country to make vaccine effectiveness, among others, working better in the country for the future, inshallah. Thank you very much for your attention.
Thank you so much, Kamal. So I think, so as you mentioned, that vaccine effectiveness results is one of the key components of, among other components that should be considered by decision makers and policy makers for making any decisions. So as you mentioned, also you showed evidence to decision framework that has many components such as feasibility, acceptability, equity, that all should be considered, by decision makers. But we have also that efficacy and effectiveness, that this kind of results can fill that part, to fill that part in that evidence decision framework in front of the decision makers. So I can see that we have a few questions in the agenda. So if you want, Kamal, you can go through those questions and then we can just open the floor. I can see also Dr. Mohsini hands on. So you can ask the questions and then we can give the floor to colleagues, RITAG and NITAG colleagues to discuss. Thank you.
Yes, thank you very much, Mernaz. Just we have put some questions just to brainstorm and to guide discussion among this group and our participant online, as well as to take guidance from the RITAG who are present with us in order to make sure that this question could be really in the future and on the ground well established. So we have been putting the question, how the RITAG is supporting the NITAG, and this has been already initiated in the last couple of months, and then we will understand, and you will be understanding that you have a country level body and a regional level body that would support you when we are going to the immunization policy decision maker. Also, we would like to explore what are the utility of vaccine effectiveness when it comes to new vaccine introduction. So now COVID-19 vaccine has been introduced, finished. But do you think that this is the end of the day? This is the end of the roadmap? No, we have a long roadmap in front of us when it comes to every new vaccine. And I'm telling you, if you go back to your country, you will see that there is a list of new vaccines that are waited to be introduced in the national immunization program. Some countries, they have 6 vaccines. Some countries, they have 12 vaccines. Some countries, they have 20 vaccines. So some countries are different from other, and every country are keen to introduce new vaccine for a better protection of the community. And then the last question related to the slide that I have been showing in green and purple, how we can bridge this gap. We have been discussing with colleagues here individually that gap is existing, and gap sometimes is very small in some country and sometimes is very wide in another country between the research team and the NITAG group or the NITAG team in the country. Also, there is a last question related, what are vaccines beside COVID-19 vaccine that could be of your interest? Start doing research on it and propose recommendation to the NITAG in your countries. As I said, there are a lot of vaccine waiting. We have been discussing early this morning quickly the RSV vaccine, respiratory syncytial virus vaccine, which is coming very high in the global agenda, and it will be introduced after being pre-qualified by the WHO to many countries, and already 5 countries in the region started sentinel-sized surveillance for RSV. So there are a lot of work to be done in the future, and that's why we need to understand what do you think that you can do for your country in order to establish a decision for the NITAG for the new vaccine introduced. So I think these are just a brainstorming question. You can prepare your question while Dr. Azzuddin coming to us now with his intervention. And then if there are more than one question, please write it down. After Dr. Azzuddin is finishing his intervention, we can go question by question. Thank you. Back to you, Dr. Azzuddin. Dr. Azzuddin.
Okay, thank you very much, Kamal, for this very comprehensive presentation. Thank you also to Dr. Arash and all the group for this excellent initiative. Why I'm saying this, actually, I'm just to give a couple of very short general comments, particularly on the involvement of the academia in the decision-making process in our country. You know that this is not happening, except in very few countries. We know that this gap or between the capacity, and I'm always saying that we do have in the region very strong academia capacities and operational research capacities, but they are not either. I think the problem is from the both way. I don't think that ministers of health are very keen in most of the countries to talk to them and to involve them with the involve. I mean, sit on this word on the decision maker process. Or perhaps the academia, in some academia, are really out of the scope, I would say, and I know from some countries that they are not really. We can see research studies done, but they don't really fit with the priorities of the country. So this gap is huge, and for this, I'm very glad to see that actually we are focusing. I'm afraid that we have done this work because of the pandemic, because something was very important and pushed us to do this issue. But I would like to see that this actually will happen in the future in our countries. I'm talking especially about EMRO countries. Now, as it was highlighted by Dr. Kamal, I think I have listening to all the presenters from since yesterday. Sorry to say it, but this is the reality. I have not heard none of them from no one of them pronouncing the NITAG. And this is I knew about this. And if you look at how many NITAGs have been involved by their ministers of health in the policy and strategy making and rectifying and follow up and monitoring for the COVID-19, very few. So this is again a problem. This is not a duty I mean, this is not the fault of the presenters, and in the contrary, I think they have done an excellent job. I know that the system in the country is often not there. So, and we are talking about NITAGs. I mean, Sumi is there, and there are colleagues from EP. I will tell you, that I would say a high proportion of the attacks are not functional. Either they are not really doing the work that you are expecting them to do, and they are just, approving all what the Minister of Health would like to put on the table and to pass as recommendation. And this is the reality. So most of them, they are not independent. And most of them, they are not functional the way we would like to see. So this is a big problem that we started to tackle recently. The RI tag has been actually reshaped recently. And we are very much focusing now on getting from the country level the priorities of the countries and the problems to try to see how much we can address them either at the regional level or at the global level in SAGE. For that, I think this, so the other issue is that we don't have this, I would say, the culture, frankly speaking, in the region to work together. So usually, sometimes even within the same Minister of Health, we have different departments, and each one is sitting on its data. Each one has its vertical kind of doing things. We don't share. So for this reason, I'm very glad, and I would like to thank and to applaud this important meeting and this initiative done by the region, actually bringing other departments and working together with DCT, with AHA, etc., and trying to address this issue through the process that we have presented, which is an excellent process actually, and which really will, I would say, ensure to some sort of persistence and perennity to this kind of work. This is one. Second, as it was said by Dr. So this is mostly focused on COVID, what was done, but I think it's a good example too. COVID is still with us, Kamal. We are still going to receive new vaccines for COVID, and we still need to do such studies to know about the effectiveness and the strategy and the policy according, as it was said, to age groups that will be targeted, according to the strategies, etc., etc. However, don't forget that we have a couple of new vaccines coming, and this is a very, very, very important tool for the post-introduction evaluation. And even after a long time, you know that we have been doing since long time, actually, measles vaccine cost-effectiveness studies during outbreaks. But we are expecting more now. I'm not saying that we need to do this for every vaccine. So again, we need to agree perhaps together and within the RFTAG on what are the indication to use this kind of tool. However, one of the vaccines that is actually been recently introduced and will be more introduced, which is the malaria vaccine. And this vaccine is very important, and we know that it is not 100%, I would say, efficient. So we will need definitely, and we know that there are different kind of strategies actually, even recommended by SAGE. So SAGE will not be able to say what is the best strategy because it's contextual. However, SAGE will base the recommendation on what is happening in the country. So we need to listen from the countries, their experience and how much effective this vaccine were or these strategies, because we have different strategies. So I think again, I applaud this initiative. And from the RI-TAG point of view, as it was announced by Kamel, we have already started talking to countries and working with countries. Perhaps we will need more capacity building in RI-TAGs, but we need also more advocacy. And here I'm here talking to Dr. Arash in particular and the senior management in WHO EMRO. We need to bring to the attention of ministers of health that we have strong capacities in their countries, and they need just to go to them and work with them and involve them in determining their priorities and developing the most suitable strategies and policies. Over.
Thank you very much, Dr. Azzeddin. Maybe before going to the floor to start discussion, this very valuable point, can we ask our colleagues, other RI-TAG member, Dr. Billy, Dr. Karar, and Dr. Baibo, if they have to add to get from benefit also as a NITAG, toward this role of putting the research before the decision maker and the role of NITAG in that. So maybe we can have some input from other NITAG member before going to back to the participants.
Yes, I'd be happy to chip in, Dr. Jamal. Thank you for this very important session. I also would like to speak with the background of my membership in the PDVAC, the Product Development Vaccine Advisory Committee for the WHO, which looks at new vaccines that are under development that are not yet ready to be rolled out. In that role, we try to prioritize vaccines for every region. And it's unfortunate to say this, but the data from our region, from the Middle East and North Africa region, is always the least solid or the least developed. We have a huge gap in the information about any and all vaccine preventable diseases. There are some countries that are not representative of the whole region that have active research and have publications that reflect many of these infectious diseases. But there are huge countries with very little information that is published about the scope of infectious diseases that they have to deal with. And that makes our job in trying to prioritize vaccines for our region a very difficult job, because we lack the evidence, we lack the data, and we have to rely on extrapolating data from other countries and other regions to say this must be important for the EMRO region or the MENA region, and work accordingly. So I urge all the participants, I know every country, the structure of the NITAG differs from the other one. The underlying structure should have input from research facilities that are interested in communicable diseases. So if there are no members of the NITAG who are active in research, there should be either a connection with academia and research facilities, another connection with the surveillance unit at whatever the Ministry of Public Health or whatever, so that those three can communicate, can share information, can share data about the burden of different diseases that are currently vaccine preventable and that will be vaccine preventable in the next decade. So we're trying to formulate this vision for vaccination priorities after 10 years, the 2030 vision. And to be honest, so far, we're doing a lot of guesswork about what is relevant and what is important for our very heterogeneous region, extending from Morocco all the way to Afghanistan. So we need to communicate this to the NITAG, and I'm happy that many are in the audience now to start doing some work in trying to get this research structure in place for the near future. Over.
Thank you very much, Dr. And I can't agree more on your point, a very important point, which is the link and the gap net which need to be bridged between the research and the decision maker. I think we will go back to the floor after the next presentation by Dr. Arash. So we will go to the next presentation and then we will open the floor for discussion on both presentations.
Many thanks indeed. Thank you, Kamal. Thank you, Mehnaz. And before I go to my presentation, I can't stop myself to say a few words. First of all, it's a real pleasure to see Dr. Mohseni, to see Dr. Khalifa, to see other colleagues. But I mean, I would highlight Dr. Mohseni and Dr. Khalifa. I mean, Dr. Bile is a role model in the WHO. I mean, sort of knowing him before I joined WHO and sort of knowing about his good work in different countries and also his commitment to Somalia. I mean, since many years in many programs, this is really impressive and I'm really grateful. And Dr. Mohseni, I mean, when I sort of assigned to WHO work and I came to EMRO here, he was one of the first people I met in terms of discussing the program. He was acting director of Department of Communicable Disease, and it's a pleasure to see you and all colleagues. And of course, it's a pleasure to know other colleagues as members of RITAG and NITAG more closely. The other thing I want to highlight is that I'm also very delighted for this session, the way that deliberation is going. This is a result of a lot of interaction and collaborative work between the Department of Science Information Dissemination and Department of Communicable Diseases. And sort of having this session in particular, obviously, we work very closely during the vaccine effectiveness studies, as you are very well aware. I mean, sort of in terms of the program, but I mean, this session in particular was the result of discussion between, I mean, Yvonne Houghton, who is the director of communicable disease, and sort of colleagues from the department, and as well as, I mean, with sort of with us on the science part, and in a way, it's linking with the program. So what I'm going to do now is actually, in my short presentation, I'm going to take a step back, looking at the sort of regional agenda for use of evidence of policymaking in general, and then again linking that to the vaccine effectiveness discussion. Obviously, we will hear more about that program from Dr. Khair Anish later in the day, that she will give a more detailed agenda on that program, which is really important to colleagues in the region, not just because of the work you do in vaccine effectiveness studies, but in terms of all important elements of evidence to policy processes. Okay, so the focus of my work is large-scale national studies and evidence-informed policymaking. This is not a technical, I would say. I'm not going to talk about methodologies, linking those. It's more of a sort of the concepts. And the excuse of using larger scale is actually, by that, I want to link it to the vaccine effectiveness studies as a sort of type of, I mean, the ideal vaccine effectiveness studies are meant to be larger scale. Otherwise, they do not provide the evidence that you expect. So that's the context of this talk. So I will talk a little bit about sort of, I mean, I will refer to the regional agenda for evidence-informed policymaking, the program we are following. And then, as I mentioned, Mehnaz will give much more details on that shortly today. Then sort of a reference, what sort of larger scale studies we usually talk about in this context, and then the sort of what and how and the requirements of the use of these larger scale studies and how the vaccine effectiveness studies actually contribute to sort of the context of decision making, and that would follow what Kamal very beautifully presented earlier today. Okay. So I'm really proud in so many grounds, but mainly I'm really proud by the decision that the ministers of health of the region made in 2019. So it was in the regional committee that was held in Tehran. I mean, the ministers every year they gather in one city in the region and they make decisions for the work of WHO. And within that meeting, I mean, the agenda for evidence-informed policymaking was approved, and this agenda was in a few fronts exceptional for the WHO, specifically as the focus was not on the methods and approaches and messages, was actually on national institutional capacity for evidence-informed policymaking, so that how to strengthen countries further. And this has been the program we are following. One of the reasons, I mean, the work during the COVID went the way it went was actually the work, this resolution in 2019. I mean, so which just after, I mean, it was approved in October. Towards the end of the year, we had COVID around the corner coming. So within that program, we talk about different approaches for evidence-informed policymaking. There's knowledge translation processes. I mean, when we talk about national policies, how national policies are informed by evidence. So perhaps, I mean, depending how you interpret it, you can put the role of NITAGs as part of that knowledge translation process. I mean, how different sources of evidence become immunization policies, for example. The programs related to health technology assessment. So using health technology assessment again, so this has a lot of linkage with immunization policies. National program for guidelines. I had a quick reference to that earlier this morning in the context of COVID-19 management guidelines. Then the issues related to use of data and sort of national data from national information system, the routine data that is coming and how it's being used for policymaking and how it should be used. And then ad hoc studies, which we could link, for example, we can refer to vaccine effectiveness studies as sort of ad hoc studies, because these are not the studies that you expect to be done everywhere, every time, as Kamal was also highlighting earlier. So then, in a way, they are done as need. The importance of this concept is not to listing these elements, because these elements have existed. It's actually identifying and highlighting the need that these elements should talk to each other. We cannot have a HTA program in one department of the Ministry of Health, a guideline program in another part, a sort of a data use in another part, not talking to each other, not sharing data, sort of. And of course, we have a situation that these may not even be available, but it's really important when they are available, they are harmonized. So the approach is called and is identified in the technical paper that were released in 2019 as the integrated multi-concept approach, which talks about systematic link about the program. And this has been the program we are actually been focused on, and we are working on it very strongly. And the regional action plan that was released in 2020 has the details of that agenda. And that's the agenda. And my colleague Mehnaz and her colleagues will be very happy to give you details about the agenda, how we are working with different countries and how this is going forward. Okay, so that's the nutshell, that agenda, some details of it, I mean, as I mentioned. In terms of usual large-scale studies referring to those, so I mean, obviously, I mean, cohorts and case control studies, obviously, we know case control studies could be also quite a small size, but I mean, but then they are also done in larger scale studies. What we usually get out of these studies is a sort of I mean, not always for case controls, but I mean, it's possible. It would be a sort of cause and effect things, mainly between the risk factors and the outcomes related to the risk factors. So when you want to know what causes what, basically. So whether, I mean, and as we are all aware of, so and those provide valuable. But the most important thing is that these studies usually do not tell you what to do with that. It tells you that smoking causes cancer, but it doesn't tell you how to reduce the smoking or what should be the national policy for the smoking. So in a way, there is always a quick jump among research committee and even policymakers that as soon as they know a relationship, they assume they know how to handle it. So they just sit together, okay, let's make decisions. So that's what these studies do not provide, but they provide very important issue, as I highlighted. Routine data from healthcare facilities or from other sources of, I mean, health data, they are an important source of evidence for the decision making. The best they do usually is to tell you where the problem is. For example, you want to know the access level, you want to know the utilization level, you want to know how the behavior of the service provider. And all of these are conditional that the data is really good and well structured, which is also not a condition that easily met. The other source, I mean, I categorize this as studies because basically they could be a source of large scale studies. As for example, in some of the vaccine effectiveness studies, I mean, if I remember correctly, correct me, but I remember your first study specifically was using actually routine data, which was actually quite a positive surprise globally, how the routine data was being used to sort of generate vaccine effectiveness estimates. Then I mean, multi-center randomized controlled trials. I mean, these are large scale studies. When they are done, they show you the effects of intervention. So in a way that they are very much linked to the decision. If they are providing other studies, vaccine effectiveness studies, policy evaluation in general, quasi-experimentational studies, when you have a policy and you want to assess the effect of that policy, they can be really helpful. And then obviously the surveys. And surveys, again, they're of a nature of, I mean, very often they can be used to assess the impact of not the impact per se on their own, but to show, I mean, the potential changes after a process. But then also they show the level of problem, the challenges that exist. And then all of these, I mean, in a way, part of the package. The most important thing that, I mean, knowing, and I say that based on primary data and based on talking and analyzing the behavior of the policymakers, is that often when policymakers are talking about evidence, they're actually talking about evidence that tells them what the problem is. And much more rarely they talk about the evidence that tells them what the solution is. So I mean, so talk to policymakers and that, are you using evidence? I would say invariably everyone would say yes. Very rarely someone says, oh, I'm not going to do that, or I'm not doing it. So that's not possible. But then give me example. Policymakers, I would say experienced policymakers, they talk of how certain data told them there is a problem here or there is a problem there. So that's important for us to understand if you're going to help them to distinguish this use of evidence from the other way of using the evidence, moving from problem to the solution. Okay, so again, so that's an array of studies. Then my next slide is about sort of categorizing those areas of studies against the key policy questions. So I mean, policy questions, I mean, these are sort of a rough categorization. Is that so questions about what the problem is, what should be my priority for action? I mean, sort of if I'm sitting in the NITAG, is there a disease that, for example, I want to add a vaccination? But I'm talking about sort of general policy making, what should be the priority, what should be the top approach. The other one would be that what are the safe, effective options and solutions for that problem? So I mean, it's one thing to say that people are suffering from mental health. It's a totally different thing to say which interventions actually help managing that suffering from mental health. And they are not that visible. I mean, it's on from knowing that it's not easily identified what the effective solution is, something that is not easy to communicate anyhow. But then whether those options are cost effective, more than that, whether they are affordable. So it's being cost effective is about sort of whether the money I put it, do I get enough out of it? So that's worth doing that. But affordable is that, do I even have the money to put for it, let alone sort of, I mean, and separating affordability from what cost effective is really important. I mean, to simplify this problem is that sort of imagine I'm talking about my time when I was a student. So as an example, so I was sort of wanted to buy a PC for myself, was my first PC. And at the time, the Pentiums had just arrived. And I was thinking of doing one of those 400 category, 486 or whatever category, or going for a Pentium. Everybody said Pentium is actually much, much better. Go for Pentium. But then I didn't have money in my pocket to buy Pentium. So it wasn't affordable, although it was going to be more cost effective. So I went for the affordable option, started with 400 category, and then later on moving to the. So that's how the governments also decide. It's not just about this vaccine is really cost effective. Do I have money to do it? And then is the money going to be with me for the longer term? Is it feasible? Is it acceptable? Is it the society going to that? So, and those policy questions, I mean, different types of evidence I refer. So household surveys, facility user surveys, data that can inform all levels. They can also complement the data on effectiveness. They are used usually to complement data on cost effectiveness. So they can actually help answering the questions in the middle. And the routine information surveillance also the same, including surveillance related to communicable disease. Interventional and cost effectiveness studies are the key sources of evidence for the questions in the middle. And then obviously qualitative studies can be really good for interpreting data again at every level, but specifically for feasibility concerns, for the identification of the key answers. And then usually we try to categorize these in different products, knowledge products. I mean, policy briefs could be, I mean, but more importantly, health technology assessment reports, guidelines that coming with this disease management guideline or program guidelines, and then also the fact sheets of the veterinaries that come forward. So why this is important? Because that's how we actually are guiding our program. So there is a lot of work that, I mean, some of them Mehnaz will highlight later, tackling some of these elements when we know in the region there has been limitation and there is need for enhancing national capacity for those areas. Then the issue is that we listened to Kamal earlier, Mehnaz referred to that, and sort of the work actually also Kamal and Gerald have been doing in previous events. So they're focusing on the sort of, I mean, what we call from evidence going to decision, what are the concerns? I mean, this honeycomb collection is just as a sort of demonstration. So within the work of the SAGE and related to vaccine immunization. I mean, there is a good concept that has been established globally and is being followed, that concept. So you need to think of different issues, not just, I mean, the effect, but also different concerns that the policymaker may or may not have. So now let's going back to vaccine effectiveness studies in this context. So first of all, as it has been highlighted earlier and discussed in this session, in a way, vaccine effectiveness studies, more or less, if I want to simplify that, we say it's a policy evaluation type of study. The policy has been approved, the policy is on the ground, you want to see whether it's actually working or not. You look at the effectiveness of it. So it would be like a sort of, I mean, you introduce your policy for reducing, let's say, road traffic injuries in the country, and then you do a study to see whether the road traffic injury has been affected and in what elements. So in a way, that's the context, that's really important to bear in mind. In a way, usually you have already made your decision, obviously. So then in a way, the way you deal with this sort of evidence is a bit different. But at the same time, vaccine effectiveness study can actually go back to the cycle of the original decision. So for example, if vaccine effectiveness study shows, oh, actually on the ground it's not effective, you may actually say, well, I mean, let's look at the decision we made. Do we really need to continue the sort of the vaccination program? So it informs, and by informing the decision is not just inform if you have done it yourself or if a team in your country has done it. The vaccine effectiveness is a source of decision making for global policies, for national policies, and can feed from other countries coming forward. And it can also help cost effectiveness. But most importantly, and this was also highlighted earlier, I remember Thomas referred to some aspects of it earlier in his remarks. The issue is that the vaccine effectiveness study on its own, I mean, you have the result of it. On its own, it doesn't tell you exactly what's happening. It might tell you about the problem. It doesn't tell you what to be done. Let's say if I have a vaccine effectiveness study and the results are not that positive, what does it mean? It could be actually vaccine implementation has gone wrongly. Could be the cold chain has not been followed properly. It could be about the sort of, I mean, problem in the batch of vaccines. So it may not be about the vaccination program. It could be about the product. It could be about the sort of, I mean, the way that the population behavior has changed. It might be about the, say, mutageneity in the disease itself. So all those things that we discussed, they actually affect the results of the vaccine effectiveness study. In that sense, vaccine effectiveness studies are similar to what we refer to in terms of, I mean, observational evidence in a way, because they are not really about proving the effects. They are showing that how the intervention works in the practice, and it could be confounded by many other approaches. We are not having sort of that sort of the power of showing effectiveness the way that we intended in fully up. Also, in a way, you say if a vaccine doesn't work in practice for one reason or the other, as a policymaker, that's good enough for me, because, for example, if I need to revamp my national policy on vaccination or revise it, or then that has a message for me for action. So if I go back to the slide that I had earlier, so I want to sort of, I just did to try to populate it in the context of immunization policy, just make it more, I mean, contextually relevant. So I mean, the different types of studies that we talk. So household surveys, etc. I added burden of disease studies there because that's the thing that would help usually which vaccine you go for. So one of the arguments our region has, some countries in the region have, when they are sort of, I mean, the sort of vaccination agenda for prevention of the cervical cancer. In the region, that's the only vaccine right now that is preventable by, the only cancer right now that is prevented. The second, what is the first one?
Cancer, liver, hepatitis B.
Oh, yes, okay. Yeah. But then we do vaccination not for that cancer. We do vaccination for hepatitis B, for many things, including the cancer, of course. Yeah. No, but I mean, here is specifically, yes. It's a cancer, it's a vaccine, and then there is and some countries in the region argue saying that, oh, the burden is not that big, or it doesn't apply, etc. And an argument that WHO argues back saying that, well, I mean, probably your data is not showing you everything, so you need to be more careful, and we are highly recommending countries adopting that. But at the same time, so that's the sort of evidence coming in. Routine information and surveillance, in vaccination agenda, one of the key surveillance things that almost every country does, and I would say probably colleagues can correct me, I think almost every country in the region does it as well, is the side effects about vaccination. Vaccines that might have side effect, whatever, whether it's done really well or not, that might differ from one country to the other, but it's something that is part of every national vaccination program. So that's the sort of evidence, again, informs policymaking really well. When it comes sort of the interventions and cost effectiveness, obviously we are talking about RCTs in the vaccine context. I mean, well discussed also earlier. I'm not going to repeat that. On qualitative part would be that what is the perception of the public? How the policymakers are perceiving the vaccine itself, how the providers of healthcare. I can tell you, I recall, I mean, as WHO encountering senior clinicians randomly, and then they're arguing with me sort of against why vaccination is not needed and what could be the risk. And then, so if you don't understand those things, you do not know what you are dealing with. And then you can think of how to harness. And qualitative study is a major source of it. We heard from one country of the region recently, they had a challenge for a routine vaccination program. So then qualitative evidence could help the country to better understand how to tackle the issue. And then lastly, the line that is added in full is vaccine effectiveness study. As I highlighted, this is a key study. It doesn't mean that it has to be done in the country itself, but it can inform actually the 4 categories of questions in terms of the immunization policy. So it can be really helpful in the process. Why I'm finishing my presentation, I think this is my last element that by this line, the reason is that actually before COVID pandemic, the evidence of any vaccine effectiveness studies being conducted in the region is really rare. We couldn't find any published study. I mean, that I can say black and white. So, I mean, and we are not talking about one specific vaccine. We are talking about vaccine effectiveness studies full stop. So in a way, the COVID has had this benefit, and we heard from colleagues that sort of the evidence from the region has not been ideal related to vaccination. Then hopefully this capacity can enhance that those processes in the future, and that's how we look at it from WHO perspective, obviously. So this is our effort to support and enhance national capacities for evidence-informed policymaking.
Thank you so much, Dr. Rashidian. So now we will have 10 minutes for discussion, question, answers from colleagues here and also colleagues online. Dr. Nawal, please.
Well, I'd like to inform you that actually I'm a member of the NETAG, so not all NETAG, not here. And I used to be the chairperson in the past, but in the last 4 years, it's Dr. Ahmed Suwaidi. I'm the vice chair. My question for vaccine effectiveness, okay? Now, when we plan vaccine effectiveness, do you suggest that as we start to introduce, let's look at the RSV, for example, there's no vaccine effectiveness for the RSV vaccine, especially the one that is recently approved, except randomized controlled trial. So do you suggest that as we look at whatever evidence we plan our vaccine effectiveness, so when we implement it, we'll be able to identify the vaccine effectiveness within a year or 2? This is 1. 2, do you think there are still a benefit to look at the vaccine effectiveness when it comes to influenza and the impact not only on influenza, but look at other impacts like cardiovascular disease? There are scattered evidence from all over the world, but actually within our region, we don't have a very good evidence. And number 3, yes, cancer and vaccination. We are one of the countries that implement HPV long time ago. And we could see the impact, but now when I evaluate the evidence, we didn't really do a good effectiveness study. So I think it's worth now to go back and do proper effectiveness study for the HPV. Thank you.
Thank you very much, Dr. Nawal, for this question. Actually, I'll try to answer a few of them. As you have mentioned, in order to go for a vaccine effectiveness, we really need to have a good coverage. So maybe we can plan for vaccine effectiveness for RSV when its coverage is becoming high. I'm talking about the HPV because actually this is very close to my heart, and I'm actually the focal person for HPV introduction in the region. UAE has introduced nationwide the HPV in 2018. Not Abu Dhabi, and I'm talking about the national level. Yeah, UAE has introduced it in 2018, actually. The coverage didn't reach so high. However, the policy has been a bit changed. But I think this is a good time, as we are discussing with API program, and maybe yourself as an ITAC person would encourage to start working on HPV. As it has been mentioned, this vaccine effectiveness might change the policy, might kind of give more evidence about how the program is performing and how is the impact until this point of time. When it comes to RSV and or influenza, is it worse or not? I think I leave this to Dr. Azzeddin, to answer you this question. So Dr. Azzeddin, would you be kind enough to answer this question related to while we are preparing for RSV introduction, is it wise to start planning for vaccine effectiveness, as well as how do we do in order to make sure that influenza program is running well? Is it worth enough to start doing a vaccine effective analysis for influenza, because we have scarce information in the region? Back to you, Dr. Azzeddin.
Okay, I'll be very brief, and this is actually my views. Good question, and sorry, Dr. Nawal, we have not met before, but Dr. Suwaidi is member of the ITAG actually, and thank you for highlighting that you are an ITAG member. I didn't know that. So I think now for planning in pre-introduction, I think this was your question. Shall we plan in the pre-introduction phase to do that? I don't think we have to do this. I think we introduce the vaccine, and then when we have the vaccine when we have rolled out the vaccine and we have good coverage, and when we have problems and issues, then we have to think. And this is what actually was highlighted by either Dr. Kamel and Dr. Arash as well. So we do that when the vaccine is there, when we have high coverage and we suspect problems, then we can look at this issue to know if we have adopted the right strategy or not. And as it was said very well by Dr. Arash too, I mean, this will tell you, it will not tell you the problem, but something is going wrong, either with the vaccine or the strategy, or you need to look at that. Now, for HPV, I mean, my problem, I was thinking about HPV because I cited actually malaria, not HPV. HPV, the problem is you need actually to get information on the disease, and the impact of HPV, you know, it's a very, very long impact. So it's not like the other communicable disease. So we have to think about this issue. I'm not saying neither yes or not, but I think we have to give it a thought. Studies for flu. Again, it's a problem with the coverage. You know how the coverage in the region is in terms of flu. You know, even if you look at the high-risk groups, I don't think that there are countries that have reached or could reach, for example, more than 80%. I do have some data I don't have in mind, but I know that we are still struggling even to cover the healthcare workers. So this is the first. Second, the flu vaccine is changing almost very rapidly, and so we need to I mean, it can be done, but we need to have a good indication. Why do we need to do that, and for which age group, for which population, and etc. etc. So this is in brief. So we don't go systematically for the vaccine effectiveness studies unless we have all the ingredient or criteria that were cited by Dr. Kamel and Dr. Arash. Thank you.
May I come in? Dr. Pillay.
Please, Dr. Please.
Yes, thank you so much. Thank you. I was very, very carefully and eagerly listening to this rich exposure. I think the subject and the discussion, which is the effectiveness of the EBI vaccines and how that could be conveyed to the policymakers, decisions taken, action as follows, is by itself not a new dimension, but it's a new a type of engagement I know that WHO was before any pre-qualification, they should have certainly verified certain minimum standards for the different vaccines. But the fact that we are engaging NITAG, the health sector itself, the universities and academic institutions, who often not only do not communicate but have a fragmentation and mistrust, etc. This forum, for me, is a new window of opportunity for all of us, and I want to start from Rashidian, and all the other colleagues who are engaged in this program for this special opportunity that you are offering to us and to the NITAG and to the ministries of health and to the universities. The only country that I know, I'm not sure if it's still the case, but I know that where the universities and the Ministry of Health have one unified governance is in Iran. In all other countries, the fragmentation is quite substantive in many cases, and at times they are not even on speaking terms. So I think this will create, for the first time, that communication. And I think for me, the process is more important, or as important as the outcome itself, because then the people will learn from each other, will communicate, will trust each other, and they will all, turn their direction to the community, to the children who are and people who are receiving those vaccines. So I just want to commend the initiative, and I hope that we will pursue that goal and will keep that communication, and will make this opportunity a globally owned at national, international, and community level. So I thank you so much for that, and I'm really glad that I'm part of your modest team listening to you. Thank you.
Thank you, Dr. Bile. Dr. Cairo, online, and then Gerard, and then Dr. Nabil.
Thank you very much, and I really benefited from all the sessions. When we look at the prominence of the NITAG in the country, actually, I agree with the comments that most probably the national platform is not well used for advocacy. But during the COVID, that was a chance for us in Sudan to get a very prominent, actually, sort of platform to give our contributions to every step, starting from the early phase and the health workers prioritization and the very severe disease and the rest of it. There was a number of conferences actually suggested and managed by the NITAG with different professional bodies and the health worker associations. And there was a big work with actually the students associations in the medical sciences field. And I think that actually got us to a better step. The next one is when the vaccines were introduced. We had very big sort of advocacy at community levels regarding the way the vaccine is introduced, and a number of platforms where we discussed the different side effects and discussed the structure with dealing with the adverse side effects reported to the platforms. I think as far as research is concerned, we had some researches, but like other countries, we didn't have very big nationwide researches until the Gavi sort of initiative availed some of the funds, and then people actually, some national research groups were involved in that. Thank you very much.
Thank you, Gerard.
Just
comment, I think, in line with all what has been said. So concerning the vaccine effectiveness studies, I think it's very important. And as we saw in Kamal's presentation, it's very well considered in the second domain that we look at when we are trying to do evidence to recommendation processes for immunization policy making. So the immunization policies are not cast on stones. They can always be updated. So a country that has already introduced vaccine, as Dr. Arash presented in his last presentation, you can get in a situation where you may need to update a policy, or your vaccine effectiveness study can very well be very important for another country that has not yet introduced the vaccine. So it's very important, and it has its place. For most of our countries that don't have, or they didn't conduct, or what we usually do is we usually go into the WHO position paper and we find information around vaccine effectiveness for the vaccines of interest. But those vaccine effectiveness studies that are considered in the WHO position paper are coming from somewhere they were implemented in some countries. So why not also the countries in our region be involved in the carrying out those vaccine effectiveness studies that these themselves can use, so other countries in the region can apply. And going beyond the vaccine effectiveness, as we saw, each of those other domains that we look at when we are doing a vaccine policy making decision, whether it's acceptability or feasibility or resources or the burden of disease, they definitely involve research. So it therefore means that the academia, or those who are involved in research, they have a very important role to play to generate the data that the NITAC would definitely use in making immunization policy decisions. So forums like these are very important in the process. And various secretariats in countries that support the NITAC are either the EPI program. In some countries, they are really academia. For example, in Uganda, it is in the university, the secretariat for the NITAC is based in the university, and that really increases the dynamics between the NITACs and the research bodies, and makes research information very much available. So we have a lot of research that can come into the decision-making process, and we just need to work along with the secretariat as well as the NITACs to make whatever research in the country available for decision-making. Over.
Thank you, Gerald. Dr. Nabil.
Yes, thank you. I just wanted to ask Dr. Azzeddine. It's of great pleasure today to have Dr. Azzeddine with us. I want to know how to cross the bridge between the academia and the NITAG, because I don't know how to act, how let you hear me. This is the first question. And I have two comments regarding the RSV introduction, vaccine introduction. Dr. Amal said that Egypt is one of the countries that will introduce the vaccine soon. But I know we have to know the burden of the disease first, then go ahead to introduce such vaccine. Am I right, Dr. Kamal? You are not agree on that?
No, Dr. Amal has mentioned that Egypt is working on sentinel site surveillance, but nothing related to decision-making yet.
Yeah, sorry for misunderstanding. The third one is about human papillomavirus vaccine, because it's my field of interest for several years ago. And I have attended a meeting a few months ago conducted by one of the big companies that promote the vaccine in Egypt. And a lot of doctors are present, gynae professors, as well as pediatricians, and someone from the Ministry of Health. And they push all the attendants to implement this vaccine in Egypt. I asked them two questions. The first question, what is the available vaccine in our country? We know that in human papillomavirus, we have bivalent vaccine, including 16 and 18, tetravalent vaccine, and nanovalent vaccine is the nine variants, including 9 variants. What's already available in one country, in our country till now, the bivalent vaccine. This is the one issue. The second issue, what is the common variance in our country. I have several studies regarding the variants, human papilloma virus variants. 16 is actually present. It's about 60%. We have several researches. 16 is present with prevalence about 60%, but 18, its prevalence is not exceeding 5%. And there are other variants not present in this vaccine, either the bivalent or the tetravalent. Some of them were present in 9-valent, which is too expensive, and we cost effectiveness study in our country. I think it will not be available to be implemented here in our country. And we found some variants not included in any one of the 3 available vaccines. Thank you.
Dr. Najafi, thank you, Dr. Nabil.
Yeah, just a comment about the issue about the vaccine effectiveness and translation, the knowledge of vaccine effectiveness to the policy making. I mean, the story is, again, is knowledge translation, and it's not so different from what we have in other areas, like, for example, non-communicable disease. Look at, for example, diabetes, cancer, and cardiovascular disease. Everyone knows that, for example, prevention is more effective and cost-effective than treatment. But look at the countries. I mean, huge expenses on the backbone on treatment and diagnosis or something like this. So the story is not different from non-communicable disease, not from any area in the public health. So, I'm just thinking that, again, we need to use the both push and pull strategies for knowledge translation. All those strategies can be effective, at least we hope so, in Middle East. And the other things, I think, Dr. Rashidian, is very important to, again, try to survive that action plan signed in Tehran, because it's very crucial for all countries if they want to, go forward regarding the knowledge translation and implementation of the evidence. Thank you.
Rania and then Francisco.
Okay, I would like first to thank you all for this interesting session and highlighting the role of NITAG is important and vital role of NITAG. My comment is based on what was mentioned by Dr. Nawal, on that we in the region we don't have more studies and on influenza. We just to highlight that last year we started working with the 3 countries inside our region to have and conduct burden of disease for influenza. And this year in September this year we started working with other 6 countries in the region to have and to conduct epidemiological study and have a burden of disease for influenza. And also we are working now with our colleagues in headquarters to Stefano and Shidza to have a burden averted studies for influenza, seasonal influenza vaccination. And just to, this is, I know that's first or preparatory steps to have more and more studies inside our region, but I want to I want to highlight that we are on our way to have more and more studies and to encourage more countries inside our region to have to conduct more studies to highlight the burden of disease, to have evidence-based studies to convince the decision maker to introduce and to increase the demand of influenza vaccination inside countries. Thank you.
Thank you, Rania. Francisco?
Thank you. Going back to Dr. Zainab Nabil comment on the burden of disease. And related to RSV, we at Bahor region, we are preparing the RITAC in 2 weeks to make some recommendations for introduction of RSV vaccine in pregnant women. As you know, the vaccine has been introduced in the US last month, And some countries in the region have already approved the vaccine. It's the case of Argentina, Brazil is ongoing, Chile, and all in conjunction with the monoclonal antibodies. So we as a Bajo region, we need to provide some guidance, recommendations to countries that are considering introduction. First of all, we need to understand the burden of this disease, the magnitude of the public health problem to really understand is this a problem and who is at risk. Is it under 5, under 6 months? Is it elderly as well a problem? So we need to really understand the burden of disease. And this is actually related to the surveillance. So I think the first step is to strengthen surveillance to understand the burden of disease. And not only for understanding the burden of disease, also to assess the impact of the vaccine once introduced. How many cases have been averted? How many hospitalizations? How many deaths have been averted thanks to the vaccination? And this is the impact. And then we can assess as well the economical impact as well. How my system has saved thanks to the vaccine. So these are several activities that can be conducted in parallel with the vaccine effectiveness studies. For the RSV vaccine, we don't have vaccine effectiveness studies so far. We have vaccine efficacy from 2 clinical trials with, I think, is 7,000 people included in the clinical trials. It's not many, but that's what we have. And some countries decided to introduce the vaccine despite the lack of evidence or limited evidence. There are some signals of safety, but we need to assess. And some Bajo region will be probably following US recommendations and following, the introduction, and we will produce real world data, but we need to introduce the vaccine for that. And this is something that we are looking at the US experiences specifically for this. And this is going to happen maybe in a couple of months. We will provide some vaccine effectiveness estimates for RSV. That was my comment. Thank you.
Thank you so much. So I cannot see any new hands on here or also online. There was a question from Dr. Nabil to Dr. Azzeddin about how we can, bridge this gap between researchers and NITAC members. Could you please just answer this question?
Thank you, Dr. Zainab. I mean, what shall I say? I mean, the problem is if we have this gap, it's because of the both parties. So most of the time, so it can be in some countries. I'm not going to talk about Egypt because I don't know really the situation, but I know almost in all the countries. I think what I said is that we don't think from both sides that we can even be synergetic and benefit from each other. So perhaps government sometimes they don't base and in most of the countries, in fact, except 1 or 2 in the region that I know, they are really using the capacities and the competencies they have in the country in terms of academia to make all this, I would say, evidence-based studies and to monitor, etc., etc. Now, I think if this is not happening, and which is the case actually, I would just call you, academia and our people there in Egypt and other countries to make the first step. I mean, and the example is here actually. You have done very good studies and you have 2 options. Either you just publish this and you keep this on the shelf somewhere else, or you go and try to contact and to be in touch with the Minister of Health. I'm sure we have a lot of opportunities. We have a lot of meetings, events to go and present and show your results to the Minister of Health. And I think you have to start making the decision makers in your country consider what you have produced. But definitely, you have to be in line with the country priorities. I mean, what is happening in some of the countries, I'm not going to cite countries, is that academia is very far from the country priorities. They are just academic and even in teaching. I mean, in some countries, we are still teaching like 10 years ago. I mean, we are not really changing according to the context and the change in the country. So I think you need to go to do the first step. You need to go and show your results. I mean, we don't do studies just to publish. I'm sorry, but we do study just to benefit and to make the people benefit and to change our way of doing business if it is needed. So, Dr. Zainab, I know you very well. I'm sure that you will go and you will try to be in touch with the colleagues in Egypt. I know them, and I know that you will come to consider what you have produced, and I think this is very important. So do the first step, and I think things will change. I hope. And I'm sure Dr. Arash, he's more actually competent than me in this domain, so he might give you better advice, I'm sure.
So I know Mehnaz is trying to move on in the agenda. We are behind, and I'm sure because it's the second day, colleagues have travel plans, some colleagues, etc. So just what I mean, I cannot refuse your invitation, Dr. Mohseni, just to say a few words. Well, I mean, this is a constant issue. So it's not just, I mean, I look at it not from a NITAG related discussion. I look at it from the whole concept of, I mean, researcher, policymaker or decision maker context. And then also, I'm not sure, I'm not aware of, for example, the level of engagement of, for example, NITAGs themselves with the Minister of Health, etc. How does it work? How close is it? How I mean, those advice is taken on board? Because again, advisory bodies in country to country, the power of their decision is different. What I can say is that, I mean, this should be looked at beyond the discussion of, I would say, sort of specific elements. You should go from a perspective of institutional processes. I mean, this example is a work so that we work with sort of institution here within the WHO. I mean, the work between the two departments has not been about sort of, I mean, individualizing the work. Is actually is about how the programs can go together. I mean, the way we actually work with country offices would be the same concept. So we were very religious. I would say my colleagues were very religious to make sure everything goes through the country offices, because structurally that's how WHO supports countries. So that's how we do it. I would say the same in the countries. And the regional action plan has a lot of details on that. My suggestion would be that maybe after listening to Mehnaz's presentation later today, to see which elements would be more applicable, and then thinking how those can be used in the context. I also understand, for example, from the SAGE background, there is plenty of also additional information that could be of use in the context of the immunization policymaking process.
Thank you, Dr. Arash. Thank you, everyone, for the great discussion. I just want to also add that, you know, it's not about just the results of vaccine effectiveness studies or kind of a specific studies. If we want really to not only generate the evidence and also to have it used by policymakers, this means that we need to really institutionalize the capacity for using evidence for policymaking. This is something different. I mean, till we don't do this, I don't think so that, you know, we will have kind of routine use of evidence or research evidence for decision making. Good afternoon, colleagues, again. So we are just waiting all colleagues to join us in the hall. So colleagues online, can you hear us? Yes.
Yes, we can.
Thank you. Thank you so much. Thank you. So now we have our last session of this regional meeting, which is the closing remarks session. So before listening to Dr. Arash Ashidian, Director for Science, Information and Dissemination in WHO EMRO, about his closing remarks, I will give a short presentation on the regional strategy and agenda on evidence-informed policymaking. So I will take you out a bit from the frame of vaccine effectiveness studies and COVID-19 vaccine effectiveness studies. I think after 2 days, you know, just discussing merely the issue of COVID-19 vaccine effectiveness study, it will add a bit, you know, kind of taste to what we did. It's more general topic. I want to just explain a bit that what has been done so far in the region since 2019, after the resolution that Dr. Arash kindly mentioned in the Regional Committee in 2019 regarding enhancing the capacity for not only generation, but use of evidence for policymaking. Okay, so this is what Dr. Arash just introduced to you, which we call it integrated multi-concept approach for evidence-informed policymaking. This is the concept that is endorsed within that regional committee resolution in 2019. And as Dr. Arash mentioned, this shows that not only this, as you can see, the hexagons around this evidence-informed policymaking in the center, these are all the sources, the main sources of evidence and data. And what we are saying that not only we need to have in the ministries of health, in the health systems, to have this training, these technical programs within the Ministry of Health, but we need to have links between them. So whenever that we have a kind of guideline program, it needs to be fed by HTA results, health technology assessment results. And whatever that we have here, this means that the best available evidence comes from all these technical programs will cause evidence-informed policymaking in an efficient way. So there were two main requests in the resolution in that regional committee. One of them was to establish the regional network of institutions for evidence and data to policy. So this network just was established in 2020. At the beginning, we had just about 13, less than 13 members from some of the countries in our region. And I can say now that now we have 36 member institutions, and these member institutions, they are not individuals. I'm talking about academic and research institutions, departments, relevant departments within the Ministry of Health in our region. Now we have 36 member institutions from all countries in our region. And this is, I can say, very active and interactive network regarding evidence-informed policymaking. And this network has also 14 additional supporting institutions, which are global and regional well-known institutions on evidence-informed policymaking, that they assist us in terms of technical capacity building of the member institutions. And the secretariat is in the unit, which is evidence and data to policy team within SID division. Again, as also Dr. Arash mentioned, there was another request from the resolution in 2019 to have a regional action plan to implement the resolution. Heba, my colleague, just kindly distributed the regional action plan. You can see in front of you. This is the regional action plan, which is developed and published in 2020, which includes 6 main strategies, 3 for member states in the region and 3 for WHO, to how we can enhance this capacity in institutionalization way for using evidence to inform policymaking processes. So, and if you just, I mean, later, I want to ask you, it would be great if you can just look at this regional action plan. You can find several actions and several activities under each of these strategies that shows how gradually countries can enhance their capacity to institutionalize using evidence for policymaking within the health system. So from now on to my next slides, I will just talk about what we did. I mean, the strategies on the right side, what we did, what WHO did in the region to enhance this agenda. Regarding the support, the regional, I mean, enhancing the regional capacity in support of EIPM, evidence-informed policymaking, one of our main program is enhancing development and adaptation of public health guidelines and clinical guidelines, which are evidence-based guidelines. For this specific program, we have different types of support that to our countries in the region. And I will go just to some of them as an example. For example, we support some of countries like Qatar, Ministry of Health for Qatar, for adaptation of some guidelines, specific topic guidelines, the priority topics to their context. But we have also a kind of bigger and huge program as what we are doing for Egypt, with Ministry of Health for Egypt, to establish the national program for guideline adaptation, which is a very, very important program. And after having this national program in the Egypt will be the first country in the Eastern Mediterranean region that will have the integrated national program for guideline adaptations and development. I really want to go. These are all from my heart. The things that I'm saying, I really want to go to each of them in details, but I know that we don't have time. So I will just introduce the topics. But if you are interested in each of them, please you can contact us and I can, explain to you more in details. Also, we developed the regional roadmap for guideline adaptation. There are some guidance from WHO developed, but the issue is, when you go to the country on the ground, you need some more practical tool to support countries in implementation of the program. So we have developed the regional roadmap for this purpose, and it will be published just in few days. It's under kind of formal edition and publication process. In just this year, October this year, we had our 17th regional committee, and we had one pre-technical discussion about guideline program. And we tried to raise awareness, knowledge, and to highlight its importance for our ministries of health. And we really, I think that I can say that we received many positive feedback from the participants and representatives from countries in the region. We did a survey on guideline to just check that what is the status of guideline program, guideline adaptation and development program in the region. This year, we did this with the ministries of health, and we received about 70% of the country's responses. And this is also the basis for us to how we can support more countries in terms of their capacity and their needs. Also, I would like also to introduce another initiative that we had for guideline adaptation and development program, which is our online workshop series. That it's on great methodology and using great approach for guideline adaptation. We had our first workshop just 2 weeks ago, and the next one will be on 23rd of November, and the third one this year will be on 11th December. So I have put the poster there, which includes also the links, the Zoom links to join this workshop. So if you are interested in guideline and in great methodology and approach for guideline adaptation, I do recommend to attend these workshops. And this is not the only workshops that we will have. This is the starting of our workshop series on great methodology, which will be followed by more workshops next year. Regarding policy brief, that was also a question that Dr. Rashid, you just asked yesterday. For policy brief, we had several trainings that I can say. Among them, we had 3 main region-wide workshops for policy brief, development, and use. That we had one which was about the general principles of the policy brief, and we had 2 advanced one for policymakers and one for researchers. In one of the workshops, we described that what are the key elements and components to be considered by policymakers regarding the appraising the policy brief results to use them for decision making. And we had another one about the methodology of development of the policy brief, which was mainly for researchers. And I put the link here. If you want, you can just go through this link. You can see the recordings, also the presentations, and all materials just we use for those workshops here through this link. Also, we developed a template for policy brief. Of course, you have seen that, there are many policy briefs developed by many institutions in our region or other regions, which some of them are 100 pages, some of them are 1 page, so different types of and different content of policy briefs. So what we did, we developed a template which shows that what are the key elements and components to be included in the policy brief to have a useful and quality policy brief to be used by policy makers, which is the end user, of course, of any policy brief. So this is also, we introduced this template, we piloted this template with some of the countries in our region and also with other departments within the WHO regional office and headquarters, and it will be published very soon again this year. We are doing some joint development of policy briefs. This is also another maybe kind of interesting area of work that if you want to have some policy briefs on some high priority topics in the country, we also have this plan to develop policy briefs jointly with ministers of health and with countries, mainly with our net-to-be member institutions. Regarding rapid response process, so I can mention two of our activities, three of our activities regarding COVID-19, and another main activity that it's ongoing for rapid response system. As Dr. Arash mentioned, at the beginning of the COVID-19, not at the beginning, after 1 year having that COVID-19 pandemic, we assessed 10 technical treatment, protocols, national treatment protocols, to see the level of medication safety considered, and also to see their alignment with WHO and international guidelines, recommendations, and the results were very, I can say, disappointing in many cases. But at the same time, it was very helpful for us to advocate countries about the issues regarding their guidelines on COVID-19 treatment. Also, we developed 15 case studies with 13 countries in our region, again, during COVID-19. And we did this, I see that the countries who are here, for example, Pakistan, Egypt. So we did, these studies with many of you, also Morocco. So these case studies showcase that how countries, they used evidence and data at global and local level to inform policymaking in response to COVID-19 challenges. So it's published, and at the end I will show you the link to access all of what I'm saying now. So we also had a seminar in 2022 last year that we had kind of right now technical discussion. We brought together all researchers, and we discussed about these case studies and the results and how we can take them forward to inform more our decision makers within the Ministry of Health. Another initiative was that regional COVID-19 vaccine effectiveness study that I'm not going to talk about it. You are aware of it even more than me. And then another program, main and I can say huge program that it's ongoing, and we have it's to establish the rapid response process using artificial intelligence in our region for evidence-informed policymaking. This is the way that we want to address policy questions from policymakers and ministries of health within few days and months with the best available evidence. And this will, I think we will pilot it early next year, and we will formally launch this program next year. About technical capacity building, so we had several capacity building in terms of COVID-19 policy brief, evidence-informed policy making, general topic, and also some components. But I want to introduce this training package. This is the web-based training package for evidence-informed policy making. The reason that we developed this package is we just realized that as WHO, I mean, how many trainings really we can hold for countries in our region, and even in the trainings, how many people they can attend. So and also we realized that there are many trainings, materials available online that they are from credit and valid sources, but we are not aware of them. Many of us are not aware of those, available and existing training materials. So what we did a systematic search through all credit sources to identify training materials on these 13 subjects that you can see on the right side of this slide. So these are all key components for evidence-informed policymaking. So we try to identify the trainings which are available online and free of charge. We check the quality, we check the source, and after having this appraisal, then we included in this training package. So I will show you the guiding flowchart that is developed for this, which is also available through the link that you can see here. I put the link. So through that link, you can just access to this training packages, which is, I think, that very a source of very well-known and very well source of knowledge, I think. Also, there are some other technical products, which some of them has been developed and some of them are in progress. For example, we have a rapid advice tool, which will be launched in 2024, early 2024. This is a I would like to bring attention of my country office colleagues to this point. This is very easy tool that through this rapid advice tool, you can identify the priority key actions for the country considering to their context, to their setting for institutionalization of evidence-informed policymaking. So this is a very, because the first thing that we need countries to have is to have their national roadmap, to have their national action plan. And this is a tool that can support countries to identify their priority actions regarding having evidence-informed policymaking in the country. So there is a glossary definition for evidence-informed policymaking just to have a common understanding of the key components of EIPM, which is also will be published in December this year. And there is another tool which is, I'm not going through the details of these items because each of them, I mean, takes time to explain. You know that HTA, Health Technology Assessment, reports how much is important regarding giving you the results of cost effectiveness of the technology that we also discussed in some of our discussions yesterday and today. So, but the issue is conducting a new HTA needs expertise, needs money, needs time. So the one of the best way is to transfer, to adapt the results of conducted HTA studies to the national context. So for doing that, there are some tools available, but there are many shortcomings in the available and existing tools. And some of them are not applicable in our region, considering our challenges and our capacities. So this is the tool which is somehow I can say the final draft is developed. We had a technical consultation just this year in February. We invited many famous I can say institutions on evidence on HTA topic from the region and also at global level, and this regional tool will be also ready very soon. We did a net-to-P survey this year, which also it was very, I mean, the results, Roberta, she's smiling now. So the results is very, very, very interesting because I mean, we just realized that these are the results that we can really build up and to support countries in terms of enhancing the capacity in using evidence for policy making. So this is the guiding flowchart for that web-based training package. So if you go through this link, you will see this flowchart. This flowchart, just there are some questions for policymakers and for researchers that can guide them. That, for example, if you have a question, what is the best package that you can find you can find relevant training materials relevant to that specific questions. So regarding country support, I mean, in addition to what I said, that these are mainly region-wide support. In terms of country-specific support, we have Somalia, Morocco, Kuwait, Egypt, Palestine, Syria, and Tunisia, which are the pioneering countries. So we have started working with them. With some of them since 2021, and with some of them like Palestine, Syria, and Tunisia just recently to support Ministry of Health for enhancing the capacity for use of evidence for decision making in the health system. For example, there is a knowledge management center which is established, the second one established in Muhammad VI University in Morocco, and now we have planned together for development of some policy briefs and some systematic reviews, scoping reviews, which is ongoing. And we will have some workshops, more workshops next year for Morocco colleagues. There is evidence to policy unit established in the Ministry's Office, in the Ministry of Health for Kuwait, and we will have a delegation from Ministry of Health Kuwait just in November this year to have a kind of face-to-face meetings in terms of enhancing the capacity for evidence-informed policy making. In Somalia, we are in close collaboration with National Institute of Health and also the Department of Policy and Planning within the Ministry of Health, that we have some joint activities, just initiated with these two institutions in Somalia. And we have, as I said, that we have that plan for Egypt in terms of establishment of a national program for guideline adaptation and development. I also want to ask you to go and check this link just in top of this slide, which you can find some of our short informative videos. It's about maximum 3 to 8 minutes each video. It's not more than that, but in each video you can find many information about regional agenda, about evidence-informed policymaking, and there are more videos in progress. So we will upload very soon more videos also here. These are all short informative videos on evidence-informed policymaking. And also there is a special edition which is published within Eastern Mediterranean Health Journal in July 2023 this year. And also I put the link here for you. In this special edition, you can find global, regional, and national studies and case studies regarding use of evidence for policymaking during COVID, and also beyond that, regarding generally use of evidence for policymaking. Okay, thank you so much. I just put the link here. This is the link for evidence and data to policy webpage. If you just go through this link, you can find the materials, everything that I just explained now in my presentation. Through this link, you can have access to the relevant materials, including recordings, presentations, and whatever that we have. Thank you so much for your attention, and sorry if I took time more than what was planned. Thank you so much. Thank you. I will give it over to you, Dr.
Okay. Many thanks, Mehnaz, and for the detailed presentation and referring to areas of work. obviously, I mean, if there is any area of interest, engagement, please reach out to colleagues. So, I mean, Mehnaz and her a small team are really active and responsive to those areas. Obviously, the vaccine effectiveness is only one area of work that the team is doing, but I can also link to colleagues sitting here. So Malika Tamim, who is over there, and Roberta Tusk back there. And of course, I mean, the support team, you know, Heba and Hala, who's been instrumental also for the conduct of this.
Sorry for interruption. I wanted to mention their names later, but so
then
I didn't forget it. I mean,
no, it's the job of me, not your
Yes.
job. So I'll do that. So don't worry. So I mean,
Thank you.
the thank you notes are from
Thank
my
you.
side. Yeah. So, but before going to the closing remarks, I mean, just informally among colleagues, any reflection, any quick reflection colleagues want to make? Colleagues online or in the room? Yes, please, Zia.
I think this is like, remember your one slide that this is not, luxury. Research is not a luxury, but a necessary thing. So, especially in the EMRO countries, when you go to politicians, this is something new for them. That you have to listen to the faculty member, and they will show you the evidence, and then you react accordingly. So thank you so much for giving importance to this research. And leadership is extremely important. So if, in WHO, I worked before in WHO, research was not a priority at the country office or at the regional level. Now with you here, I think this is a new era for us, for the researchers. And I think I'm extremely happy that it is getting a start, and inshallah, in the days to come, we will really work hard on this and make an impact. Thank you.
Dr. Nabil.
May I also comment that, extensively, and say that we will be very grateful if the data presented in this meeting could be also shared.
Sorry?
The slides.
Sure.
Sorry, all the slides will be shared very soon after this meeting during this week.
Thank you so much. Thank you so much.
I wish to thank the WHO and the WHO team in particular to give us this great opportunity to share in conducting such research. Me and Dr. Iman just talking a few minutes ago about we have studied a previous study about the vaccine effectiveness for hepatitis B, but the design and the statistical analysis are completely different. We learned a lot from such a project, and we are so proud of being members in this, conducting this project with your support and your advice all through the time. Thanks a lot for you.
Thank you so much for your kind words, Dr. Nabil. Francisco, please. Okay, thank you, colleagues. It seems that we have received responses. 2 colleagues still they are typing, so we will wait to. Okay, thank you. Thank you so much, guys. Thank you for participating in this also assessment as well. Thank you for your patience and collaboration. So I will just give the floor to you, Dr. Arash, for your kind closing remarks. Thank you so much.
Okay, many thanks. I mean, well, I start with some thank you notes. I'm really grateful to all of you traveling to Cairo for this important meeting from I would say some from very long distances, but also from countries in the region. So I'm really grateful to all of you, and also grateful for the work you have done on vaccine effectiveness studies, whether as part of the regional work on vaccine effectiveness studies or as individual studies that have been conducted in your countries or your regions. Similarly, very grateful to colleagues online for being with us for the last 2 days and engaging very effectively in the meeting throughout. So that's, I mean, all in all, the meeting has very clear messages for us for action, and also how to take the work forward in the final steps of the work that is going on. So in the same line, I'm grateful to my colleagues in the country offices. I mean, they're working very closely with the teams at the national level, supporting the processes, engaging well with the regional office team, and sort of a through regional efforts from the WHO perspective. And there has been challenges in all areas, and without persistent, vision and also commitment to the work, it would not have been possible to move forward so far. Similar thanks go to colleagues in HQ, in the teams in Geneva. We've worked with several colleagues at different stages of the work, and some colleagues are present today. They were present online, but other colleagues were not, so I'm grateful to that. Within the regional team, obviously we have representatives active in the session from the Communicable Disease Department, namely my colleague, Dr. Kamal Fahmy, but also we had other colleagues with us earlier and other colleagues who were not in the session that have been a strong support to the study. What we missed most of the time was colleagues from the emergency team, the department. They were part of the major part of the study from the start at different elements of it. Some colleagues have left the region, some colleagues were involved in the sort of emergency response and could not be with us. So for that, I'm also extremely grateful. I would leave, the sort of a specific thanks to the EDP team. So for the strong work that they did, this was a mandate that was done through the pandemic work, was not part of the usual job that team does. And it's done, Mehnaz in particular, but also colleagues in her team that have been really persistent, following, engaging, collaborative. And within that also, I mentioned the Malika, Roberta, Heba, and Hala, and not just for the studies, but also for the meeting itself. But then another colleague who is online, she's been working with us in the last 2 years, specifically in support of this regional study, Dr. Zahra Karimian, and so she could not be with us in person in this session, but I'm really grateful to Zahra as well. So, with this all said, this is really a pleasure for us to host this. And for me, 2-3 actions are sort of very clear. One is that obviously the next steps of this study. The other one would be the clear messages that can come out of it. Through the scientific reports and publications. Again, the nature of that will be finalized by the team, and also policy briefs as applicable. And policy briefs are will be focused on the findings and the messages of the studies, but also on the process, on how such studies could be of use on that. And that will be also in line with the, I would say, the agenda of WHO in support of such studies. There were many good examples, especially, while we were discussing the technical aspects, we were most concerned about the limitations. But when we engage with the colleagues who are dealing with the decision-making process, they actually selected to highlight the positive aspects very prominently, how such a capacity is needed for the region. I was really glad to hear this, as sort of from our department, and also the 2 other departments I mentioned. There has been quite an investment of time, and I'm glad this investment is in line with the policies. So many thanks. Yeah, of course. Yeah. So no, I should have also highlighted. I'm sorry that I missed that. So in a way, when I refer to WHO teams, then I conclude all the support teams. So that's MMGH. I should not miss that. So we have colleagues with us in the room, but also colleagues online. So we are grateful for the level of engagement, and also I'm really grateful for the team because they are bringing all the experience from the years of work on the vaccine program globally and within the WHO to support of the region in this area. Anyone else I might have missed? So it's really important not to miss at this stage. So obviously we will be in touch next steps, and we take it forward further, and again reach us to us. Anything that you think we should do better, anything that you have ideas and proposals, please share with us, and we will be very happy to work further with you. And I look forward to seeing you in other opportunities in future events. Thanks.